Hello.
Good morning, sir.
Sir, good afternoon, sir.
Good afternoon.
Good morning, Ganesh sir. Good morning.
Sir, good afternoon, Samir here.
Good afternoon, sir. Veersha, can you please wait, Veersha? Get back to your screen. After I tell you, please share. Dr. Veersha. Sir, good afternoon, sir. Just hold a moment, sir. Dr. Veersha, can you please unshare? Stop sharing, Veersha. Dr. Veersha. Sir, good afternoon, sir. Just hold a moment, sir. Yes, sir. Dr. Veersha, can you please unshare?
Unshare.
Good afternoon, sir. Just hold a moment, sir. Yes, sir. Dr. Veersha, can you please
Unshare.
Thank you, Veersha. Thank you. May I request all the participants, apart from the faculty, to stop sharing your video, sir. Only participants and faculty can keep the video up, please. Can you others please stop sharing the video? It disturbs the class. Thank you, thank you, thank you, everyone. Please unshare your videos. I request all the participants, apart from the faculty, to stop sharing your video, sir.
I am conducting the examination now.
Oh, online.
Hi, Dr. Tanaka,
Yes, sir. Prakash,
Hi.
sir, welcome, sir.
Dr. Ramanaya.
Sir,
Hi.
welcome, sir. Prakash, sir, Ramana, sir. Thank you for joining, sir. Allow me 5 minutes, sir. We'll start the class.
Yes, yes.
Right.
Vivek, sir, you are with us?
Yes,
Yes.
Ramana, sir, and Prakash, sir has come, sir.
Yeah. బాలాజీ కొంచెం మంచిగా చాయ్ పెట్టాలి.
Wait for a few minutes for Abid Alvi sir to come. Other faculty are already available.
Samir has come.
Samir has come, sir. Samir has come.
Sir, good afternoon, Samir here.
Hi, Samir. Good afternoon. Your photo has not been seen here.
Sir, I'll keep the video on, sir.
Okay.
Faculty, please keep the video on, please. Faculty, please keep the video on. I will call up Abhay sir for a moment.
So you can see అన్ని చూడొచ్చు దీంట్లో ఇట్లాగే వీడియో ఆఫ్ చేయమన్నారా
ఇంకా ఒక్క దాంట్లో చూడమన్నారా ఆ రూమ్లో కూర్చొని చదువుతున్నారు మీరే అసలు రావడం లేదా మరి మీ రూమ్లను చదువుతున్నారా తినేసి నిద్రపోతున్నారా కాదు ఇక్కడ రూమ్ ఒకటి ఉంది కదమ్మా
బాగా తగ్గిపోయినావా నువ్వు చిక్కిపోయినావే
మామూలుగా లావు కావాలా
I request the participants apart from faculty and presenters to kindly disable their video. Only faculty and PGs who are presenting can remain with video. Please, please.
Yeah. Okay. Anka.
Faculty and presenters can be showing their video, please. Because our bandwidth is so heavy already. We have 320 students in line. I don't want any instability to the platform.
Okay. Who is the presenter at Kanaka?
Sir, this is Dr. Veer Shah from NML Municipal Medical College from Ahmedabad.
Okay, NML Ahmedabad.
Yes, sir. And then the other candidate is Dr. Meera Warrior from MS Ramaya, Bangalore.
Okay.
Dr. Abhay Dalvi is here. Good afternoon, sir. Hitesh sir, good afternoon.
Video yet to come.
Hitesh sir. Professor Hitesh sir, good afternoon.
Good afternoon, sir.
Yes, sir.
Sir, actually, right now there are COVID cases only in our hospital.
Okay, sir. Okay.
So this is the one which he has previously presented. But anyway,
I understand, sir. He expressed the difficulty of getting that vascular. And sir, I say, faculty, please help your students to allow them to present even a presented case, sir, because many cases don't have exam cases in the ward only. Because even places where they have are taking only. Sir, one moment, sir. I'll excuse. Sir, good afternoon, sir.
Hi, Dr. Hitesh. Dr. Prakash from Tirupati.
అని వైట్ పేపర్స్ ఇవ్వను మీకు. again doubts and orders keep pass and just and keep passing. నీకు రాగదే స్మూత్ గా వస్తాయి రెండే కదా. నీకు అట్లా అనిపించేది
video is mute.
more than 100 participants close అయిపోతుంది. Right from it is 100 participants. నాకు 4 అన్నాడు లేట్ గా వచ్చావు అంటే నాకు ఓన్లీ 4 అన్నాడు నా గ్రూప్ కి నేను మాత్రం చెప్పింది నైట్ గ్రూప్ కంటే మొత్తం పార్టిసిపెంట్స్ 300 అని చేయను 300 అన్నాడు 320 వచ్చిందా నంబర్ వినిపిస్తుందా స్పీకర్
Dr. Virsha, are you ready?
Yes, sir.
Many happy returns of the day, Abhay sir, and with the permission of the faculty, I am starting the class. Dr. Samir sir, Dr. Virsha, you can please share your presentation and start the PowerPoint.
Okay, sir.
Hi, Samir.
Sir, good afternoon, Samir.
Yeah, good afternoon, Samir. Yeah.
Yes. Many more happy returns of the day, sir. Abhi sir.
Sir, good afternoon. Many happy returns of the day.
Good afternoon, sir. Many more happy returns of the day, sir. Ganesh from Pondicherry.
Dr. Abhay Talvi, happy birthday.
I think he is.
Thank you. Let's start.
Yes.
Oh, I couldn't see you, Dr. Prakash here.
Not display, Abhi.
Virsha, please start, Dr. Virsha.
Yes, sir. Okay, so I'm presenting a case of a 50-year-old male patient, Kashiram, farmer by occupation, presented to the hospital 5 days ago with the chief complaints of abdominal pain for 2 months, vomiting for 2 months, and lump in the abdomen for 1.5 months. Patient was relatively asymptomatic 2 months ago, after which he developed pain in the abdomen, which was present in the upper abdomen, dull aching in nature, moderate, intermittent, aggravated on taking meals, relieved by vomiting. It was not radiating and not referred to any other site. He also complains of non-bilious vomiting, foul smelling. He used to vomit every third or fourth day. Every third or fourth day, then every alternate day, which even contained food particles taken a day before occasionally, and for 15 days, he has vomiting every day. The vomiting occurs usually in the postprandial period, is projectile in nature, preceded by nausea. The vomiting contains undigested food particles. He also gives history of vomiting altered color, that is coffee ground vomit, for 2 to 3 times in the past 15 days. He also complains of lump in the abdomen for past 1.5 months. Initially, the patient has distension of abdomen, which became more prominent after meals, after which he consulted a local doctor who told him that he had lump in the upper part of his abdomen. The lump has increased in size over 1.5 months, which was initially of smaller size around 5 centimeters and has gradually increased to present size of around 15 centimeters. It has increased gradually with no sudden increase in size of the lump. He also complains of constipation for 15 to 20 days that passes stool once in 3 to 4 days, anorexia, decreased appetite, black colored stools for 4 to 5 times in the past 15 days, loss of weight 10 to 12 kilos in 2 months. He has no history of acute excruciating pain in the abdomen, colic abdominal pain, discoloration of urine sclera, fever, diarrhea, syncope, giddiness, excruciating lower limb pain, flushing, breathlessness, back pain. He has been given 2 blood transfusions after his admission. He has no history of TB, diabetes, hypertension, surgery in the past, hospitalization, blood transfusion, or jaundice in the past. He is a tobacco chewer for 30 to 35 years, consumes it daily 2 to 3 packets. He has no history of drinking alcohol. He has normal smoking. He has normal vegetarian diet. His bowel is constipated. Bladder habits are normal. Sleep is normal and appetite is decreased. He has no significant family history. Drug and allergic history is not significant. I have examined my patient. in adequate light and exposure with proper consent of the patient. Patient is well oriented to time, place, and person is conscious and cooperative, fairly built, poorly nourished. 18.7 is the BMI, 60% is the Karnofsky performance scale. He has no pallor, icterus, cyanosis, clubbing. Edema is present over both lower limbs, which is pitting in nature. Inguinal lymph nodes are palpable bilaterally, form non-tender, sub-centimeter size, no other lymphadenopathy. Pulse is 84, blood pressure is 102/70, back and spinal normal. Local examination inspection. A single approximately 15 by 10 centimeter vertically oval ill-defined lump is seen occupying the epigastrium umbilicus right hypochondriac region, extending approximately 5 centimeters below the sternum in midline and 15 centimeters from below there, reaching up to the right costal margin in mid-clavicular line that moves with respiration, is pulsatile with no visible peristalsis or impulse on cuffing. The skin over the lump is normal with no scar, sinus or dilated veins. This is a representation of the same.
Can I come in?
On performing the Carnet's test, the lump becomes less prominent and decreases in size. Umbilicus is transversely stretched, central and inverted. Abdomen appears distended. Bilateral flank fullness is present. Respiration is abdominothoracic in nature. There is no renal angle fullness. External genital and hernial sites are normal. Patient is catheterized. A religious thread is present around the patient's lower abdomen. So this shows the lump. It's a closer picture. This is a video with the transmitted pulsations and moving with respiration. On palpation, a single normal temperature non-tender, 24 transversely, 14 longitudinally centimeter oval, well-defined lump is felt occupying the epigastrium right and left hypochondriac umbilical region, extending 5 centimeters below the xiphisternum in midline, reaching up to the right costal margin, 4 centimeters from the left costal margin, 10 centimeters from the anterior axillary line on the right side, and 12 centimeters from the anterior axillary line on the left side. The lump has nodular surface variable consistency with 10 by 12 centimeters stony hard lump palpable in the epigastrium and right hypochondriac region, and rest of the lump is hard with firm consistency in between. The lump moves with respiration, is pulsatile, no cuff impulse, not compressible, no visible peristalsis, and no thrill is palpable. It is not freely mobile and not fixed to overlying skin. Fingers can be insinuated between the lump and the costal margin on both sides. Succussion splash is heard. Liver and spleen are not palpable. Is the longitudinal. Percussion liver dullness starts in the 5th intercostal space, is present up to the right costal margin in mid-clavicular line, continues with the lump in mid-clavicular line. Liver span is 11 centimeters. There is dull node present all over the lump. Shifting dullness is present. Horseshoe dullness cannot be elicited due to the lump. Succussion splash is heard. Normal bowel sounds are heard. No abnormal sounds or bruit is heard. Rectal examination is within normal limits. Left supraclavicular lymph node is not palpable. RS CVS are within normal limits. My summary. My 50-year-old male patient Kashiram complaining of upper abdominal pain, which is aggravated on meal, relieved on vomiting. The vomiting which occurs 5 to 10 minutes after meals, which is coffee ground for 2 to 3 times. He also complained of lump in the upper abdomen, which is gradually increased in size. Patient has history of constipation, anorexia, decreased appetite, melanine, and loss of weight. He has been given 2 blood products after admission. He is a tobacco chewer for 30 to 35 years. On examination, he has pitting edema over both lower limbs. A single normal temperature non-tender, 24 transversely, 14 longitudinally centimeter oval, well-defined lump is felt occupying the epigastrium, right and left hypochondriac and umbilical region. With nodular surface variable, hard to stony hard consistency that moves with respiration, with transmitted pulsation, is not freely mobile and not fixed to overlying skin. Fingers can be insinuated between the lump and both side costal margin. Succussion splash is present. Dull node is present over the lump. Shifting dullness is present. The provisional diagnosis would be a gastric outlet obstruction due to a mass arising from the stomach. Thank you.
I request the faculty to take over, sir. Abhay, sir, please.
Can you go back to the history?
Yes.
What is constipated bowel?
Sir, usually any bowel movement up to 3 times a day or once in 3 days would be considered normal, and above that we can consider is constipation.
Constipated bowel.
Sorry, sir.
You have written bowel constipated. What do you mean by bowel constipation?
Oh, no, sir. I have written constipation for 15 to 20 days.
Go
No,
back.
you said so. Patient is constipated, not bowel. This is what.
Yeah. Only trying to point out, you cannot say bowel is constipated. Patient is constipated, I can understand.
Yes.
Yes, sir. Yes, sir. Sorry, sir.
My second question to you is, you said this patient has flank fullness. What does flank fullness indicate to you?
Sorry, sir.
What does flank fullness mean to you?
Sir, the flank fullness would be a earlier sign of ascites, as the fluid will first accumulate in the flanks.
So did you percuss to see?
Yes, sir. I have percussed. Shifting dullness is present, sir. Horseshoe dullness could not be elicited because a lump was occupying majority of the upper abdomen.
Okay. At the end of the history, before examination of the patient, what would be your provisional diagnosis?
At the end of the history, sir, it seemed to be due to gastric outlet obstruction due to the typical symptoms that he had. But the cause could not be confirmed. Most likely due to the stomach.
And at the end of your examination, what is your diagnosis?
Sir, at the end of the examination, it seems pretty clear that it is a gastric outlet obstruction arising from a mass from the stomach, due to mass from the stomach.
Mass from the stomach is not a diagnosis.
Yes, sir. So most probably it can be either due to carcinoma, as its incidence is high, or there can be certain other pathologies like a gastrointestinal stromal tumor or a GI lymphoma.
Or third one?
Lymphoma of the stomach, sir.
Lymphoma of the stomach. Okay. Some other examiner can come in.
Sorry, sir?
No, some other examiner, if you want to ask questions, can come in.
Yes.
Andarya Saab.
Yes, sir.
Please take over, sir.
Okay. So, what are the points which leads you to diagnosis of gastric outlet obstruction? What is the typical history and examination finding of gastric outlet obstruction, irrespective of this finding or this case?
Yes, sir. The patient will usually have vomiting, which will occur postprandially and will contain food particles even from the day before, and it will be non-bilious in nature and will contain some amount of undigested food particles. There will be a succussion splash will be heard.
How do you stop? You said postprandial vomiting. So is it always postprandial?
No, sir. In this case, it is
postprandial. When you say postprandial, it has to be the food particle which he has ingested during that meal. So yes, probably it may not be postprandial. It may get accumulated, and when it is about to overflow, it may, or it is stretching, it may, patient may vomit. Okay, first. Then
succussion splash.
How do you explain succussion splash? In what examinations you can elicit succussion splash?
Sir, usually it is better confirmed on auscultation, but if the stomach is distended hugely, it can even be felt on palpation.
How do you elicit in palpation?
Sir, there are two methods which have been described. One is that the lump can be fixed by two hands with hand, and then it can be tapped.
Outlet obstruction, you don't need to fix the lump. To elicit succussion splash, you don't need to fix the lump.
Yes, sir. So we can tap over the lump with our hand, which can lead to movement of fluid inside the stomach, which will be partially filled with fluid and partially empty.
It is a semi elicitation of dangling movement. Just you do it in ascites. You do like this tapping. Okay, that is one.
And second is, in some books it has been described that the entire patient can also be moved from the waist.
You don't advocate.
Yes, sir.
Okay. So where will you put your one hand and where will you put your second hand to elicit this sign?
Sir, one hand will be placed over the lump in the epigastrium, And second hand.
No, you are not right. So lump is a firm or hard structure, right?
Yes.
So when you put one hand on the hard or firm structure, you are probably, see, succussion splash is a sign to be elicited for huge amount of fluid which is not covering the entire hollow organ, and there is a space inside the organ which the fluid is getting shifted, and you are able to move the bubbling sound of succussion or movement of fluid. So you have to put your hand on the part which is filled with fluid. So you have to put it medial and superior to the lump palpable if it is gastric mass. Do you get it?
Yes, sir.
So you don't put it on mass. That
Yes.
is very clear.
Yes.
Did you elicit gastric movement in this patient on palpation?
Peristalsis?
Yes.
Sir, it was not possible as the patient was not able to tolerate any diet, sir, and the patient.
Gastric obstruction. This is a mass. It's a different issue. Suppose there is a patient with benign peptic ulcer and gastric outlet obstruction. Right? In that case, you will, what the signs will be present will be, one will be succussion splash. That too, when patient is vomited, you may not get the sign. Second thing is peristalsis of the stomach, which you can see in the larger area. The J-shaped stomach is many times hanging up to the pelvis. So how do you elicit this stomach peristalsis?
We will ask the patient to take some amount of fluid.
No, you have to elicit on palpation.
Yes, sir. We can move our fingers, the tips of our fingers, over the abdomen from left side to right side, like stroking the stomach.
Right to left.
Okay.
Usually, excuse me, sir, I am Dr. Anandi.
Okay.
Regarding visible gastric peristalsis,
Why do you think it is malignancy and not benign mass?
Inspection finding. We don't do it under palpation. What is your opinion on this, sir?
External compression of stomach from a benign disease from outside. What are your points? I don't say you are wrong, but what are the points to justify that this is a malignant mass arising from stomach?
Sir, the growth of the mass that has occurred over a relatively short period, from 5 centimeter to 15 centimeters, over 1.5 months. Then the patient has a history of weight loss, anorexia, and decreased appetite, which can also be present in a patient with gastric outlet obstruction, but which also go here in favor of this. And the patient has ascites, sir. Which can be due to
two more symptoms you missed.
Sorry, sir.
Two more findings you missed. History.
Yes, sir.
Bleeding.
Yes, sir. The patient has bleeding. Coffee ground vomitus is present on.
Is there hematemesis?
Sir, the patient
You
has.
asked the hematemesis?
Yes, sir. The patient has history of coffee ground vomitus for 2 to 3 times in the past 15 days.
You asked in history?
Yes, sir.
Yes, he mentioned.
Oh, actually, when will you get Melina?
Yes, sir.
When will you get Melina?
Sir, when the bleeding is arising usually from an upper GI cause that passes through the bowel and comes out through the lower GI part due to the changes in the hemoglobin. So the stool will be black tarry melena.
Yeah, good. Great.
Okay. So actually, did you mention anything about auscultar percussion?
Sorry, sir?
Auscultar percussion. Did you mention anything about auscultar percussion?
Auscultation, sir.
Will you do auscultar percussion?
Yes, sir. I have mentioned about percussion.
No, not percussion. Auscultar percussion, because you told.
How will you do auscultar percussion?
Auscultar percussion. Yes, sir. I did that during succussion splash.
How will you do that?
Sir, we will keep our stethoscope over the part that is distended, and then we will percuss over the abdomen. That will lead to a sound similar to succussion splash.
No. Question is not that. Question is, you told stomach is distended. How will you measure that stomach is distended in clinical? That is called auscultar percussion, no?
Yes, sir.
See, when you want to do an auscultar percussion, you have to use the bell of the stethoscope, keep it over the epigastric region and try to make a gentle strokes in the radial axis along the bell of the stethoscope so that you can measure the points where you can mark the points and you try to join all the points, which will give you the idea about how far your greater curvature of the stomach is going to be present. Whether it is coming down below the level of your umbilicus, indicating it is a distended stomach.
Yes, sir.
Here, one point I'll mention, sorry to interrupt you, faculties. When you don't know the answer, always say that sorry, sir or madam, I do not know, rather than pulling on. This is ultimately a correct answer. Carry on, madam.
And regarding succussion splash, when we are telling, sir, usually succussion splash is the finding which we elicit when the patient is in a lying down posture. We ask the person to take the, either it can be done usually by auscultative method, they do it. They keep the bell of the stethoscope again at the epigastric region using the left hand, and using the right hand, they gently stroke the abdominal wall and they try to elicit the succussion splash. That is the method usually just been taught for the students. But regarding this palpatory maneuver, in case of an over-distended stomach, when you have a partially filled stomach, in that case also you'll be able to hear the succussion splash by just gently shaking.
Very right.
Dr. Veer,
Yes, sir.
what are the different causes of gastric outlet obstruction apart from stomach?
Sir, pancreatitis, which can involve the second part of duodenum, can lead to inflammation of the second part of duodenum.
How,
Yes, sir.
how pancreatitis leads to obstruction?
The entity known as groove pancreatitis. Sir.
Now you are digging your grave. Huh?
That is very rare. Do you want to say that?
Now we are going into groove pancreatitis. Let me know something about groove pancreatitis, my dear.
Sir, the inflammation that occurs due to pancreatitis secondarily involves the groove, that is the second part of duodenum, can lead to.
What is this groove?
Sir, it is the area in which the ampulla will open in the second part of the duodenum.
No, what is groove? Groove.
I don't know.
Thank you. So tell the common causes first. Apart from causes in the stomach, what are the other causes of gastric outlet obstruction?
Sir, a mass arising from the transverse colon, sir, can infiltrate into the stomach.
No.
Tell common causes.
Apart from malignancy.
How many cases of pseudocyst of the pancreas have you seen while working in the ward?
A lot many, sir.
None of them had vomiting?
They had, sir. They had.
Then why you are not coming to common causes, my dear?
Sorry.
Why you are scratching the examiner into groove pancreatitis and all rare causes which...
If you know the other name of groove pancreatitis, it will be easier to remember. But forget that. That is paraduodenal.
So pseudocyst can cause a gastric obstruction.
Of pseudocyst arising from head.
Yes, sir. Pseudocyst arising from the
But
head.
benign causes commoner. I gave you one hint in the questionnaire. Though it is not common nowadays, it was common at least 2 decades ago.
Tell me where is
ulcer arising in the duodenum, sir. Duodenal ulcer.
Duodenal ulcer with obstruction, right?
Yes.
That is not part of the stomach.
Yes, sir.
Correct or no?
Yes, sir. Yes, sir.
Okay, thank you. Anything else?
Sir,
Okay, how do you elicit a visible gastric peristalsis?
Ma'am, we can stroke the abdomen with our fingers.
Inspection.
On inspections, we will ask the patient to take some amount of fluid and we will wait for around we will be at the level of the abdomen, and we'll wait for around 10 minutes. If then it
What do
can
you mean by being at the level of the abdomen?
means our vision.
Yeah, you have to say you have to be in a tangential view at the level of the abdominal wall, right? Either along the sides or along the foot end. You go to the foot end and be at the level of the toes so that you can see the vision where the wave is going to go. What is the direction of the wave in the case of a gastric peristalsis, and what is the direction in case of a intestinal peristalsis?
In gastric peristalsis, it will be from left to right, upper to lower, and in intestinal peristalsis, it will be the opposite.
What is the reason why you want to give water to the? Can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Why do you want to give water to the stomach to induce peristalsis?
Again, free air kana the class attend பண்றது.
Sir,
PG class.
I'm not sure, sir.
What does water do? It induces
lead to the activation of the maybe the stomach pacemakers. That
it induces peristalsis because something goes into the stomach.
Yes.
Okay, let's go ahead. Let's take it as your diagnosis of malignant lesion of the stomach giving rise to gastric outlet obstruction.
Yes.
How will you go about? And this patient obviously has ascites too.
Yes, sir.
Go about treating this patient.
Sorry, sir.
How about treating this patient or investigating whatever?
How will you manage?
Yes, sir. On further investigation, sir, there are investigations by which I will confirm my diagnosis, and there are certain blood investigations. First, I will do the investigations which will confirm my diagnosis, which will start with an ultrasound of the abdomen.
Why?
Sir, it will help me know the organ of the origin, which is there, though it is not very good for assessment of stomach pathologies. Later on, and ultrasound is usually cheap and easily available.
One minute, wait.
Yes, sir.
You are choosing ultrasound as a primary investigation. In the same breath, you are telling me it is not a very good investigation.
Yes, sir, just to know the organ of origin so that we can move to.
Don't contradict yourself.
Yes.
If you are saying sonography, you say sonography and give reasons for sonography. What you are going to get out of it. Don't tell me that it is a useless investigation, but still I'm going to do it. That's not going to go well with the examiner.
Yes.
Particularly when you say to confirm the diagnosis.
It's like telling the girl, you are very good, but I don't like you. It won't help. Okay? Yeah. Go ahead.
Then I will proceed with a contrast and CT scan of the abdomen.
No, wait, Veer. I would like you to answer in a way when you are sending a patient for a particular investigation or asking for a particular investigation. I want you to tell me what you are going to get out of it. So sonography you have done on this patient and you have got your examination findings. What are you going to tell the sonologist? These are the things we have examined, and I want from you many more things also apart from my findings. List out everything that you are going to ask from the sonologist. What do you expect?
Yes, so I'll ask about the organ of the origin, then the extent of the mass, whether there are any lymph nodes which can be seen, then about the ascites which is present, the amount of the ascites which is present, whether there is any secondary involvement or any metastasis to any other organs, particularly the liver. This is all I will ask. Then the characteristics of the mass, whether it is hypoechoic or it is hyperechoic.
What is the next thing?
Next investigation would be, sir, a contrast enhanced CT scan with of the abdomen.
So before that, can you plan for any other thing?
Yes, sir. We will plan for an upper GI scopy and esophagogastroduodenoscopy.
What are you likely to find in this patient on endoscopy?
Carcinoma which is arising, we will be able to see the entire mass. It might have infiltrated the entire wall of the part of the stomach, If in case it is a gastrointestinal stromal tumor, GIST or something, we might not be able to see the mass.
Again, you are going into gastrointestinal stromal tumors, which tells me that you have read about stromal tumors have come, and I'm not going to ask you a single question. You're smiling, I can see that. So when you do an endoscopy, what are the things that you are going to see?
Sir, the mass that is there, then the whether it is causing any gastric outlet obstruction, whether we can go beyond the pylorus or not, whether there are any clots or there are any bleeding spots which are present.
See, when you are going to do an endoscopy, you'll not be able to see a mass. You're going to see an ulcer. Okay, you don't see a mass.
That's what I'm trying to ask him, Anandi. I'm trying to ask him the same
Thank
thing.
you, sir.
Visualize the tip of the endoscope going in and tell me all that you are likely to see. Have you ever seen an endoscopy being done?
Yes. Yes.
Okay. If you have seen, tell me as the scope goes into the stomach, you have bypassed, gone through the GE junction. What is the first thing that you are going to see in this patient if the patient is not well prepared?
A lot of undigested food which will be present.
That is the first thing. Now let's take that the patient is well prepared and the endoscope is going in. What is the first thing that you are going to see?
Sir, ulceration of the wall.
Where do you expect?
Usually in the body and antrum, sir.
You have reached the body, but you are just crossed the G junction. What is the first thing you are likely to see?
Sir, a huge dilated stomach.
You are likely to see the normal mucosa. What will be the condition of normal mucosa in this patient? Will it not be inflamed?
Yes, sir.
Because of chronic stasis, will it not be inflamed, red?
Yes, sir.
You may find small erosions because you have given me history of coffee ground vomitor.
Yes, sir.
That will be there. Then as you go forward, you will come in contact with the so-called mass. As Anandi has correctly said, you will find a growth or an ulcer, which is large because you are palpating a big tumor. So when you are answering any finding as far as investigation is concerned, especially endoscopy, that you have seen endoscopic procedures, you should describe as if your eye is going into the stomach and visualizing things. Last thing will come that the endoscopy is unable to get into the pylorus and the pylorus into the duodenum. So can you summarize now, thinking that you are doing endoscopy, what are the different things that you will see?
As soon as if I enter the gastrointestinal junction, esophageal junction, if the stomach is not well prepared, patient is not well prepared, then there will be undigested food particles. If the patient is prepared, on entering, I might find the mucosa, which is a bit inflamed due to the chronic stasis. Later, I might find an ulcer or a growth, which is there. And finally, I will see whether the pylorus can be negotiated or not.
Very nice. Now, what is the next thing that you will do with the endoscope inside?
Sir, I will take a biopsy.
Where will you take the biopsy from?
I will take biopsy from all at least from 6 places, different areas where the growth is there.
How will you measure the ulcer? How do you know the size of the ulcer?
I don't know that. On endoscopy,
on endoscopy only.
No,
because when you're going to see an endoscopy, we'll say it's a large ulcer or a small ulcer, like that. We'll be saying no. How do you say the measurements?
I don't know.
See, when you open up the biopsy forceps, which are going to take for endoscopy, each prong is going to be around 2 millimeter. So when you're going to open it up like this, it's going to be around 4 millimeter. So when you're going to keep it like this, we can be able to see the rough size of the ulcer. Whether it's going to be around 1 centimeter or it's going to be 2 centimeter, like that, you'll be able to judge and say the size of the ulcer. Okay.
Have you seen biopsy being taken?
Sorry, sir?
Have you seen a biopsy being taken from a stomach ulcer?
I have seen an H. pylori tissue being taken. I have not seen a biopsy.
You have seen biopsy. How is it sent to pathology?
It is sent
in saline or formalin?
Formalin, sir.
Sure. Sure.
Yes, sure.
Dr. Ganesh Babu is smiling. I am asking basic questions. Huh?
Yes, sir.
I want to know whether the boys worked in the wards or no.
Yes.
Because I know he will tell me all classifications of GIST, etc., etc.
Yes, sir.
I just want to know whether he has worked in the ward. Fine, you have done endoscopy, you have taken biopsy. You have sent it for pathology examination. What next?
Sorry, sir.
What next?
Sir, based on the investigations, I will continue by doing a CT scan. And I will also do some blood investigations, which will tell me about the general condition of the patient, the hemoglobin.
Hemoglobin is 6.
Yes, sir.
Hemoglobin is 6.
Yes, sir.
No, hemoglobin is 6.
Hemoglobin is 6.
6. Yes, sir. So I'll consider a blood transfusion for the patient. Sir.
What else? You said patient has pedal edema.
Yes, sir. So I'll do a serum albumin level to see whether is nutritional built, which is there.
Albumin is 2. So hemoglobin 6, albumin 2.
So that shows that the patient is very malnourished and needs to be prepared by giving proper nutrition.
Okay. How will CT scan influence what in this patient? How will a CT scan influence your patient?
CT scan will give us certain clues about whether the disease is localized or it has spread to other parts, which can help us know whether if it is a mass, it is resectable or not. It will show us certain lymph nodes. It will give us the amount of ascites which is there, and it will give us exact measurements about the mass, and we can check for metastasis at locations. And of course, it will confirm the organ of origin if it is arising from any other part or the pathology is something different.
Now again, see this answer. The examiner is not in good mood, is going to catch you. You are
See
now
what position in which you want to take a CT scan.
Sorry, Anandi, go ahead.
Sorry, ma'am. Sorry, sir. Go ahead. The question which I wanted to ask was, you want to do a CECT of the abdomen, no? Yes. You wanted to say you wanted to assess about the infiltration to the adjacent structures and the deeper structures. In what position would you like to take the CECT of the abdomen?
The sound was there.
CECT abdomen is when you want to know about the posterior infiltration to the pancreas, they tend to do it in a prone position so that the concerned organ, the stomach will fall away from the pancreas if it's not going to be stuck to it. So they do it in a prone position. So you can go ahead, sir.
Yeah. Can you hear me?
Yes, sir.
Yeah. Now tell me, this patient has a large mass. Let us assume that there is no ascites.
Yes.
And there are no nodes. Liver is normal. It is free from cares.
Yes.
Treat this patient.
So first, I will prepare the patient. I'll correct the malnutrition. I'll correct the anemia. I'll correct the hydration status of the patient.
How?
Veer, this is an important thing. You should not say I will correct. You have to say what you have to do.
Correct.
That's what exam they expect. Otherwise, you will get into trouble.
Yes. To correct the anemia, sir, I'll give blood transfusion. To correct the nutrition status, sir, if the pylorus can be placed, a nasojejunal tube can be placed with the nutrition can be given. We can provide the patient with albumin infusions if the patient is affording.
There should not be a word if the patient is affording.
I know.
Yeah, so we'll give the patient albumin infusion, which will lead to correction of his nutrition along with hydrating him for 5 to 6 days with normal saline and ring electric, as he will also have some serum electrolyte deficiency. That has to be corrected.
What is the difference between acute dehydration and chronic dehydration?
Sir, here there will be, I'm not sure about the question, sir.
According to you, this is acute dehydration or chronic dehydration?
Chronic dehydration, sir. Chronic dehydration.
How do you correct chronic dehydration?
Sir, we will give normal saline, sir.
No, that is the fluid that you want to give. You think you can give him 4 liters in a day and correct his hydration?
No, sir. Around 1.5 to 2 liters a day.
Is it rapid correction of dehydration or slow correction of dehydration?
Relatively slow correction, sir.
Why the word relatively?
Slow correction. Compared to if it would have been an acute thing, we corrected relatively slow.
Okay, how much blood this patient will require according to you to correct his hemoglobin to 10?
Sir, around 4 pints, sir.
Why do you say 4 pints?
So usually 1.5 is the amount that will be corrected by one transfusion of PC.
Okay, good. Go ahead. So you have corrected over a period of 5 to 6 days his nutrition. His hemoglobin is gone. His hemoglobin has come up to 11. PCV is normal. There are no reticulocytes except a high reticulocyte. And the patient is ready for surgery. How will you now? Tomorrow is the operation. Today, what will be your orders?
Today, we might consider placing a central line for
there
monitoring.
Is no might in patient.
We'll place a central line, sir. We'll place a central line. We'll place a central line to the patient. We'll give the patient NDM. Next day, first we'll plan, sir, for a diagnostic laparoscopy.
No. Still pre-op preparation is not over. How will you plan?
The surgery?
So you are planning a surgery. What orders will you advise before taking him to pre-operative room?
Yes, sir. He has to be kept nil by mouth.
Is that enough?
No, sir.
Have you written pre-operative orders yourself?
Yes, sir.
What are the orders that you write?
Sir, we'll keep the patient nil by mouth. We'll give the patient antibiotic on the day of the 1 hour before the incision. We will do shaving of the patient from nipple to knee region, and we will take proper consent of the patient regarding what will be our plan of management regarding the surgery that we can undertake. It might also be aborting the surgery if metastasis is occult metastasis is found on performing the surgery.
What metastasis?
Occult, which we could not detect.
What is occult metastasis?
Basically, I mean that if we could not detect that from the imaging modalities that we had missed like that.
So if you put in a diagnostic laparoscope in this patient, you find a large node there, it is occult? It has been missed by the CT in reporting. Anyway,
no, sir. Usually the
don't use the word occult when you are doing some surgery.
Sir, that was small or that could not have been
preoperative orders. You cannot tell me pre-operative orders which are written in the patient scheduled for surgery tomorrow.
Yes, sir. Keep the patient nil by mouth. Give the dose of antibiotic day before surgery, 1 hour before surgery.
Where are you from?
Ahmedabad, sir.
अरे तू ऐसा ऑर्डर लिखता है क्या? I'm sorry, I'm talking in Hindi. What is the first thing that you write? Patient is for surgery tomorrow.
Yes, sir.
What is the second line that you write?
The surgery that is being planned for the patient is diagnostic laparoscopy followed by distal or total gastrectomy for an indication of carcinoma stomach.
हाँ. बाद में next line में क्या लिखते हैं?
Do shaving of the patient from nipple to knee region.
Then
take proper informed and written consent of the
What is
patient.
proper? What is proper?
Where he has been explained about the complications and about the plan that is exactly
Informed consent. What is
informed
proper?
No, sir, informed consent.
Is there anything improper?
No, sir.
Then why use word?
Informed consent of the patient. Then pre-anesthetic checkup of the patient.
Correct.
Then overnight a pint that is given to the patient.
IV fluids, I understand.
Uh,
Now you are a final year student, right?
Yes, sir.
So you must be having 2 juniors.
Yes.
So you will tell them, do this also. I want it tomorrow before boss comes.
Send a blood group cross match of the patient.
Thank you very much.
And one more investigation. 6 a.m. morning.
ABGA may be considered.
No, before that.
No.
Before that.
As the electrolytes are altered, the serum electrolytes will be checked.
You don't say electrolytes altered. Say serum electrolyte. That is the answer.
Serum electrolyte.
Don't chew the gum and pull it longer.
Yes.
No, your patient will be on rails tube, or you'll put rails tube on the table.
Sorry, sir.
Rails tube.
Rails tube.
When will you decide whether it is on the day or previous day itself?
Previous day, we will put a rice tube and we'll give a wash to the stomach so that all the undigested particles and the organisms that have grown can be cleared.
That point is also very important. Even in pre-op order also, you should document that.
Yes.
What about pre-op 3-4 days, 5 days physiotherapy?
Yes, sir. Chest physiotherapy will be started for the patient as it is a major surgery.
No justification required. What? Okay. Yes. The question which is asked, answer that only. Answers which are not questions do not carry any credit mark. They do carry discredit sometimes. Listen to the question for a fraction of a second and then answer. Monitor his pre-operate, I mean, day before surgery urine output.
Sorry, sir.
Will you monitor his pre-operative day, pre-surgery day urine output?
Not necessarily in every patient.
Oh.
Hey, what is wrong in saying yes?
You may not be observing, but it has to be, yes.
Yes.
Now you are antagonizing examiner from Gujarat only. Obi Ahmedabad wala. Anyway, you have taken patient on table, patient is anesthetized. And you said you will do a diagnostic laparoscopy. What do you mean by doing a diagnostic laparoscopy on this patient? And what will you do?
Sir, some peritoneal mets are not easily detected on CT scan, and some small liver mets may be missed on CT scan.
This is not the way to answer. When you do a diagnostic laparoscopy,
when we put the scope inside,
way of doing diagnostic laparoscopy.
So when we put the scope inside, we will find some amount of ascitic fluid. We will take that fluid for cytology and we will send it for cytology. And we will look inside the entire abdomen. We will look whether there are any peritoneal involvement, there are any mets in the peritoneum. Okay. And we will also look for if there are any small mets which have been missed on CT scan in the liver. And we will also look for the nodes properly, which are visible.
Nodes will tell you, if you see them large, that is likely to be inoperable. I'm not saying non-resectable, I'm saying inoperable.
Sir, the para-aortic and aortocaval nodes.
How easily do you see para-aortic or aortocaval nodes?
It requires a lot of dissection.
It requires dissection, right?
Lumbar shelf, if it is
then somebody like Palanivelu will finish D2 gastrectomy while trying to look for aortocaval nodes.
Diagnostic laparoscopy itself.
There are drop metastasis in the pouch of Douglas.
What metastasis?
Drop metastasis in the pouch of
What
Douglas.
is this drop metastasis?
Sir, so it is described like that in books that the meds through the peritoneal path, they might settle in the pouch of Douglas, so known as drop metastasis.
If it was a female, then there is some drop metastasis in the ovaries. What is it known as?
Krukenberg tumor.
Why does it reach ovary only?
Ovary are true intraperitoneal organs, as they have a connection with the intra-abdominal part.
What do you mean by true intra-abdominal and false intra-abdominal organ?
So, sir, usually intraperitoneal organs are one which are covered on all sides by the peritoneum, but they have no communication with the peritoneal cavity. The ovaries, they have a communication with the peritoneal cavity.
They are divide of visceral peritoneum. Amir, carry on.
Okay, your tumor now is operable on your diagnostic laparoscopy. You are opening the abdomen. What are you going to do? What are the steps you are going to follow now?
If the tumor is operable,
yeah,
then
what do you mean by operable? What do you mean by resectable?
Operable is when there is no spread to organs which would make it a metastatic tumor. So we can operate and clear off the entire tumor. That is operable. And resectable is when it is adherent to certain vessels, particularly the arteries, which cannot be resected and reconstructed.
Okay. No. So now what are you going to do?
You just explain what is resectability again.
Sir, the arteries like the celiac artery, the SMA, if they are encased for more than 180 degrees, then they cannot be resected and reconstructed. So such tumors we will consider unresectable. And certain major veins like the IVC, aorta, or portal vein, if they are completely involved, then the tumor may whenever a vessel which is
Veer, can I stop you here? Let's be very clear. When you say operable, the intent is to cure. When you say resectable, the intention is not to cure but partially palliate. That means you know you are leaving some tumor tissue behind. So let's be very clear about it. Don't here and there involvement of aorta, encasement of vessel, etc., etc. That is not. Operability means intent to cure. Resection means knowingly that some amount of microscopic malignancy may remain behind at the end of resection. This is the definition.
So, Veer, you are able to understand. You should be very clear. You don't need to say about vessels. Resectability doesn't include vessels alone. It's very clear. Operable means intent is cure.
See, you're talking about resectability, that is for the pancreatic lesion, which you're talking about your vessel encasement and other things. Here we are talking about the general thing in the case of a CS stomach regarding operability and resectability. By resectability here, we can resect even a tumor which is going to be adherent with that of the pancreas. We'll be able to remove it, but what happens is we'll be leaving behind some of the microscopic tissues attached with that of the pancreas. Okay, whereas when you say it is operable, we mean to that we are able to give a complete cure. There is no evidence of any residual disease. It's almost an R0. Okay, so that is operable. There should not be any metastasis should be present, like ascites or peritoneal deposits or omental. Anything should not be there. Everything has to be cleared away. Then it becomes a operable tumor, and it is we are going to give a curative intent. So that is operable.
So considering that the tumor is operable, what is the operation that you plan?
Here, look, as the tumor is very large, we will either go for a near total or a total gastrectomy.
In a radical gastrectomy, what are the organs other than stomach that you remove?
We might have to remove the spleen, the pancreas,
pancreas,
tail of the pancreas, tail of the pancreas.
Greater omentum.
Greater omentum, then the pancreatic capsule, the lymph nodes.
Now, what are the various lymph nodes? Nowadays, they call them stations, no?
Yes, lymph nodes.
Different stations.
Sir, in the D1, there are 6 stations. The station 1 will be right to the cardia. Station 2 will be left to the cardia. Station 3 will be nodes along the lesser curvature. Station 4 will be 4A, 4B along the greater curvature. Station 5 will be suprapyloric. Station 6 will be infrapyloric. And from the 7 to 11, station 7 will be celiac. Station 8 will be common hepatic. Station 9
7
will be
is not celiac.
Station 7 will be left gastric. Station 8 will be celiac. Station 9 will be common hepatic.
Again, station 8 is not celiac. Station 9 only is celiac.
Station 8 will be common hepatic. Station 9 will be celiac. Station 10 will be splenic hilum. And station 11 will be splenic artery.
By the way, the advantage of sitting in a Zoom meeting in a proper examination nowadays is that the mobile is always in hand. And let me read out what is drop metastasis. Drop metastasis, also known as intramedullary spinal cord metastasis, is a rare complication of cancer affecting blah, blah, blah. Before MRI being available, most cases of drop metastasis were diagnosed only on autopsy. Now, there is no mention whatsoever of your drop metastasis into the pelvis. Anagwele is now started smiling. So be very careful when you talk of drop metastasis. It is known as transcoelomic spread, I can understand. But drop metastasis is something different, huh?
Yes.
Okay. Now, this is not for you. This is for all others who may take home the message that we can call this word drop metastasis in the exam and get away. So be very careful. Veer is from Ahmedabad. वो गुजरात कैसे फटाक से बोलते हैं कॉन्फिडेंस से और एग्जामिनर भी भूल जाएगा. So all students be very careful.
Yes. Thank you, sir.
Okay. So let's come back to your patient. He has ascites and you have taken ascitic fluid. It comes positive for metastasis. Now, how do you go about treating this patient?
Sir, then still as there is gastric outlet obstruction, we need to establish some nutrition pathway for the patient. So we might do a feeding jejunostomy for the patient so that he can be given nutrition.
Dr. Veer, you please understand the question. By just having an operable tumor, a bit of ascites which is positive, do you see the line of your surgical extent of resection going to change or not? The question is very straight on your face. We don't want to consider feeding jejunostomy. Those things are much later. At this point, will your policy of surgery change? If it is going to change, on what basis you will change the policy of the extent of resection? That is the question. Please answer to the question.
Yes, yes. Sir, if the patient is fit for surgery, as there is also bleeding from the tumor, we might consider a palliative resection. If he is not fit for surgery, to tolerate a long procedure, we will do a gastrojejunostomy to bypass the obstruction which is present at the.
Dr. Veersha, you have still not got into the crux of the question. The current NCCN guideline says your TNM staging and TY staging. TY is the cytology staging, is not directly influential. If you have a ascitic fluid positivity with macroscopic peritoneal deposits, then your surgery have to be a restricted surgery, or as you say, for tiding over the complications. If you do not have macroscopic peritoneal metastasis, ascites CY plus, your policy do not change in the extent of resection. That is the answer you are expected to tell. Then comes the question of how much of stomach or what other things. So if the examiner expects a specific answer from you, please grab the, see, examiner wants to get an answer from you. Please assimilate the question before going to the next step. Now telling if it is peritoneal macroscopically negative, CY positive, what will be your plan in this patient?
Sir, as you said that, then our plan of management will be same as it was before. We will try to do an operative resection.
Okay, what is the extent of gastric resection you will talk? Then we'll move to the other thing. What are you going for T?
Sorry, sir?
What is the extent of resection for the T status of the tumor?
Yes, sir. Sir, it should be at least 5 centimeters proximal margin has to be achieved.
And distal?
Sir, distal margin is also preferred as 5 centimeters, but at times, as the D2 is there, 2 centimeter margin can be done.
Please quantify. You are talking about a gastric outlet obstruction, right? In that case, do you think it is technically feasible for a 5 or 2 centimeter margin at all?
A 2 centimeter margin is feasible.
Okay, if we are not able to give 2 centimeter margin, does it become you are going to abandon the procedure?
No, sir. We might consider for smaller margin unless we can do a R0 resection.
That should be the answer. See, if you are able to give a 1 centimeter margin, it is optimal. But if you are going beyond the pyloroduodenal junction, yeah, macroscopic margin negative resection is all what is to be achieved, right? That should be the right message. Now we move on to the circumferential margin. Madam was asking about a specific thing. Assuming you have cleared proximal and distal, your vessels are not encased, you are carefully ligated the feeding vessels. Now, assuming the only main problem of consideration is your posterior adhesions. We are talking about your patient, not about spleen or tail pancreas and all here. In this patient, if you have a invasion which is onto the capsule of the pancreas, what do you do? If you have an invasion of pancreatic parenchymal infiltration, what do you do?
Sir, if the capsule of pancreas is infiltrated, we usually remove the capsule of pancreas also along with the gastric tummy. And if there is infiltration of the pancreatic parenchyma, then if it is in the tail, we'll
talking about your patient. Please restrict to your patient.
Then, sir, we will have to consider Whipple's procedure also along with. If the parenchyma is infiltrated.
Whipple's in a patient with positive ascites in a CS stomach?
If it is infiltrating the parenchyma in the head region.
But will you do a palliative Whipple's for a CS stomach?
I don't say you abandon
send the patient home.
Dr.
I'm not sure.
The point is very clear. If your cytology is negative, you have focal infiltration into the head of the pancreas. And sir very clearly said your albumin level is 2. The most important risk factor for a post-operative pancreatic fistula is the albumin level. And you are going to involve another 3 more anastomosis if you are proceeding with the Whipple's procedure, minus what you are going to do, right? So on that basis, the only indication at this point of time for a Whipple's resection is experimental center where they are done on a trial basis, number 1. Number 2, well-differentiated tumors with favorable nodal status, clinical, radiological M0, cytology 0, it can be considered in level 3 and level 4 centers. That's what is the current guideline. At this point of time, as a postgraduate, you are expected to tell, I will do a minimal required procedure, right? Whipple's may be fine. Your center is a designated center for a trial. At this point of time, if there is a head invasion, you have to technically abandon the resection. If it's capsule involved, save of pancreas is accepted. All right, that should be the clear answer. Please move on. can we now talk about what are the incontiguous nodal spread and what are the skip spread of nodal disease, and how do you ascertain the limit of lymphadenectomy?
Sorry, sir, I did not get your question.
Okay, fine. We will take it like this. You have cleared the T. You have done a R0 resection. Now we are talking about N clearance. You have nodes in the prepyloric zone. You have nodes in the lesser curve. You have few nodes along the celiac axis. This is where we are talking about. Here, what will be your extent of lymphadenectomy?
D2 lymphadenectomy will be done.
Can you define what is a D2 lymphadenectomy?
Sir, where the stations from station 1 to 11 are removed.
Again, the concepts are changing now. You don't have a broad resection like 1 to 11. Now it is become regional D2. It is not a generalized D2. Generalized D2 resection is no more advocated. Regional D2 is D2 dissection pertinent to the location of the tumor. You don't end up clearing one for a antral tumor. Please understand that. So your dissection D2 definitions have changed. Now it is going to be a regional D2 dissection. A very safe way of answering D2 will be, I will go one basin beyond the clinically or surgically positive lymph node which I find during the operation. That will be the safe approach, right? At this point of time, all through D2 is not indicated for a regional tumor. That is the current advocation. All right.
Thank you.
So with that in consideration, now you have removed 5 centimeter clearance, you have ligated the celiac vessel, you end up having half the stomach in hand. Do you want to disconnect the distal end? What is the policy followed in your department?
Sorry, sir.
How do you dissect the or resect the distal part of the tumor in this operation? You mean to say you want to do a hand-sewn closure or you want to do a staple closure? What is the policy and what do you do in your department?
We usually do a hand-sewn closure of the duodenal stump.
What are the precautions you would like to take in closure of the duodenal stump?
So that the part we are closing should, that duodenum should not be inflamed.
Question of inflammation does not come, right? You do not
No, you clearly understood what there are.
You do not devascularize the duodenum, number one. Optimally, depending on your department's policy, a single layer closure or double layer closure is advised. In duodenum, second layer of closure may not be possible, especially if you are going beyond the PD junction for want of R0 resection. In that case, stapled dissection or stapled resection may be little advantageous if you are moving to D1, right? But again, D1 is done in specialized centers. D1 transaction is done in specialized centers. At this point of time, you say you will do a layered closure of duodenum. All right, fine. You have removed the stomach, removed the nodes. Now, how do you want to reconstruct this patient after the gastrectomy?
We will do a Roux-en-Y esophageal.
Please understand, have you done a total gastrectomy for this patient?
Either a total or a subtotal gastrectomy.
You have to do one. You cannot do both for the same patient, na?
Sir,
have you seen a distal gastrectomy or a near total gastrectomy or a total gastrectomy?
I have seen a distal gastrectomy.
You have seen a distal. Let's talk of distal gastrectomy. Okay. So you are saying a Roux-en-Y anastomosis.
Yes.
Right?
Yes.
So stomach anastomosis.
Sorry, sir?
Stomach was anastomosed to the jejunum.
Yes, sir. Yes.
What suture material was used?
Sir, Vicryl.
And how many layers?
Sir, 2 layers. First layer we closed with Vicryl, second layer we closed with silk. The seromuscular we took with silk.
Okay. What was it 20, 30?
So the Vicryl 20 and silk also 20.
What was the needle size? Needle size.
Sir, it was I'm not sure, 1/2, sir.
What?
1/2, sir.
26 mm needle, 30 mm needle, round body needle, cutting needle.
Round body needle, sir.
Round body needle. That much you know, but you don't know the size of the needle.
No, sir.
I'm asking you this question. I asked because all of you all don't even bother. Whatever that sister gives you, you take and start suturing. That sister knows what size to give. How big should be the needle? It should go through a thick stomach and a thin jejunum, correct?
Yes, sir.
So, I know that you have seen, but you have not checked what is the needle like. You know that it is round body. Why round body?
Sir, so that the delicate mucosa is not damaged. If we take a cutting needle, then it might tear off.
Correct. Very nice. So you have completed 4-layer anastomosis. Anything else that you saw being done?
The entire stomach was not anastomosed with the jejunum. Part of the stomach was closed primarily.
Okay. What is angle of sorrow?
Not sure, sir.
Not sure. Does not matter. No, particularly you said part of the stomach was closed and then gastrojejunostomy. So I ask you this question. What is angle of sorrow? Go back and read. Angle of sorrow is the junction between the closed stomach and that junction where the jejunum and the closed stomach takes place. That is known as, that is the one which can leak. And that used to be the fear in a surgeon's mind. And that's why it was known as angle of sorrow. Okay, I think, I don't know how much time you want to pull on with the first candidate.
Anything else? Anything else can be done, sir, asked, except the partially anastomosed and then completely anastomosed, particularly when patient is little hypoalbuminic. Anything else will you like?
Will you add a jejunostomy in this patient?
Yes. Very simple.
Yes, sir. I'll add a feeding jejunostomy for the patient.
Now tell me how is jejunostomy done?
The feeding jejunostomy may be done in 2 ways. In one, in which we create a tunnel.
Very good.
And anastomosis. Sorry, sir. Anyway, anastomosis.
Whose name?
Witzel.
Witzel. Very good. And the second one is TAM, right?
Yes. Where we directly anastomose without creating a tunnel.
What is the size of the Riles tube that you use in a jejunostomy?
We usually use a larger 18 or 20 French, but
my last question to you: how will you teach the relative care of jejunostomy?
Sir, whenever they provide some amount of a diet or food or anything, in the end they have to give 50 ml of saline to just flush the tube.
घर में किधर से लाएगा रे भैया?
Any water. Any water, they have to just flush it.
You have to flush and see that it is patent.
Yes.
Okay. Patient 1 month down the line comes back to you saying that jejunostomy is blocked. Now what will you do?
Sir, we will try to flush it with some amount of saline. And
1 month later on. So what question will you ask?
When was the last feed that was given? After the last feed, whether water was given or not?
Water wo jata nahi tha. It was not going, doctor. That's why I brought him here. Now, how will you try to open up that block?
I'll try to push it with some saline with some amount of force. I'll try to check the bulb whether it has been. I'll check the bulb whether it is hyperinflated or not.
Which bulb?
You are talking of Foley's, sir is talking of Riles tube.
No, I never brought in Foley's. He said 18 to 20 number Riles tube.
Now he is talking of Foley's.
Now he is talking of Foley's. That means he has already changed it to Foley's, which I'm not going to allow him.
Yes.
How big is your house, Veer? How big is your house?
3 bedrooms.
3 bedroom, very good. Any of the bathroom or wash basin gets clogged? What do you do?
Sir, I think you should give the answer to him, sir. He is not into the line.
We might, if it is still not possible, as 4 weeks have occurred, we might change the Riles tube as the tract is already established.
That is one. What ingredient you can use to flush?
Something to foam the content, foam and clear.
Baking soda, सुना है क्या baking soda?
Yes, sir.
Huh?
Yes, sir.
You inject baking soda solution, and most of the times this block will go away because of the effervescence that it creates.
Yes, sir.
Okay.
And the first question, whether he's taking proper diet or not. If he's taking, you may think to remove it.
Remove it. Anyway, Kanagwell, you go on.
Let me ask you 2 quick questions and move on to the next case, sir.
Yeah. Okay. Thank you, Veer. From my side,
yes, sir. You are okay.
I pass you.
Yes,
but you have to tell me that you worked in the ward properly. Yeah?
Yes, sir.
If I really come as examiner, please be very careful. You have to know what needle is used in suturing. Yes. I don't want to know classification of these.
Yes, sir.
Okay.
Yes. Thank you, sir.
Okay.
See, the policies of feeding jejunostomies are very simple and clear. If you are not confident about your anastomosis of your duodenal stump, especially when you do a subtotal gastrectomy, feeding jejunostomy is indicated, right? The most important message you have to tell to the attenders or to the patient when you do a feeding jejunostomy is, at the end of every feed, even it can be a liquid feed or whatever, the tube has to be flushed with a minimum of 20 to 30 ml of normal tap water. That is mandatory. They may say, sir, I gave only juice, I gave only milk, does not matter. It is mandatory. You instruct the patient and the attender. Every feed, immaterial of whatever be the time, has to be flushed. The entire tube length, what is outside and what is inside the intestinal lumen, which is the minimum mandate of 30 centimeter of your tube, whatever we need to use, have to be used. And number 2, for the benefit of postgraduates, people and in the center where they use Foley's catheter for doing a feeding jejunostomy, please, for heaven's sake, do not inflate the bulb. Very important. And then at this point of time, yeah, 10 to 12 size catheter is advocated. We don't definitely go for 18 or 20 because the complications of feeding jejunostomy in a bigger tube are more. Then the policy of removing a feeding jejunostomy depends on your post-operative surgical pathology report. If the patient for any reason warrant a post-operative systemic therapy, you wait for a minimum mandate of 2 or 3 cycles for your Riles tube to go. Because these patients can end up having vomiting as a perennial problem of chemotherapy. So feeding jejunostomy has to be waited before you remove. Even there is no requirement for feeding jejunostomy, you allow till the 3rd cycle of chemotherapy to be over, because most of the time your first chemotherapy can be toxic, but if you cross 3 cycles, generally after that your tolerance of chemotherapy is fairly good. All right. And then if you are doing a total gastrectomy, if your margins are positive microscopically, whatever be the adjuvant therapy, please do not remove your feeding jejunostomy tube.
Yes.
Because your survival or your tumor-free, disease-free survival is not going to be long, especially if your margins are positive. So patients' feeding access is the only source of nutrition for your FJ is the only nutritional source. All right. So keep these things in mind. And may I have one last question. Can you quickly list out the post-gastrectomy complications?
Yes, sir. So there can be the initial dumping syndrome, which is seen. It can be early dumping or a late dumping. there is efferent loop syndrome, bile reflux.
Just let me hold on you. We don't have much time. Whenever you are asked for a complication, you please discuss on-table complications, immediate post-operative complications, and late complications. Please have an order when you answer the questions, right? So that way, the examiners will appreciate your logical approach, and your systematic approach will definitely get through, even if you have not done well in the other parts. Any answer for the matter, you have a system to answer.
Yes.
All right. Considering this, what will be the on-table troubles you may face during the gastrectomy?
So there can be hemorrhage which can occur. There can be damage to surrounding structures which can occur.
Which are the more troublesome hemorrhages you have seen during a gastrectomy?
I have not seen any such hemorrhage during.
Okay, post-operatively, can you get hemorrhage, if at all? If you get, from where you are expecting to get a hemorrhage?
On the...
Is the drain for the distal gastrectomy in your department?
Yes.
Okay, where do you place the tip of the drain tube?
One in Morrison's pouch and second in pelvis.
You place 2 drains. Perfect. So if you are going to get bleeding from your Morrison's pouch drain, what are the concerns you have?
Gastroduodenal stump. Stump of the gastroduodenal artery.
That comes much later, na? You mean to say bleeding from the stump?
Yes. Bleeding from the anastomotic site.
That is usually through the nasogastric tube, right? It should not be through the drain tube, right? When you have an anastomotic site bleeding, it should be from your nasogastric tube. So the color of the nasogastric tube in the post-operative period do matter. Initial blood staining is accepted as a normal condition when you do a gastrojejunal anastomosis or a jejunal-esophageal anastomosis. But in the post-operative period, if it looks more of bloody discharge from the Ryle's tube, you are definitely concerned. Leave alone that. Then, in the first 3-4 days of period, what are the most important complications pertaining to abdomen? I don't want respiratory and other thing. Pertaining to the surgery, what are the troubles you may face?
There can be a infection of the wound, collection in the abdomen. There can be a duodenal stump blowout, which can occur. There can
What
be...
is the most common trouble you may face up in the post-operative period? I understand what these are all the potential complications you may face. Patient may say, I'm still, your junior will say, sir, Ryle's tube is about 1200 ml, and by day before yesterday it was 800 ml, yesterday it is 1200 ml, today it is 1500 ml. Are you concerned about this?
Delayed gastric emptying or ileus.
Yes. So especially when you're dealing with the totally dyselectrolytemic patient, you have to be careful in the immediate post-operative period also. That should be the immediate consideration. To quickly wrap up, can you list the delayed complications of gastrectomy?
Yes, sir. So there is a dumping syndrome. There can be early dumping syndrome or a late dumping. There can be an efferent loop syndrome. There can be a efferent loop syndrome. There can be bile reflux, and there can be anemia, which can be due to iron deficiency or folate deficiency. There can be calcium vitamin D deficiency. There can be ulcer that can occur at the anastomotic site.
Okay, so that sounds good. So I think you did a fairly good presentation, but then no, you plan your answer, right? You seem to be in urgency to tell the answers. So you take a time for you to assimilate the question, right? I am sure you have read a lot, but then when you answer, unless it is, as Professor Andarya said, if it is not going to resolve the question what the examiner is asking you, then the point of you rattling out subject may not be relevant at all here in your exam. You may end up telling, sir, I ended up answering all the questions, still I have not gone through. So unless the examiners have very clear policy, they discuss in the morning whenever they see the case itself, what are the potential areas. Most of the time examiners ask, if most of the time 2 or 3 candidates may examine a single case, the questions will be more or less same for all the candidates. Most of the time examiners concur to the finding, concur to the questions well in ahead, right? So unless you are comfortable in assimilating a question and answering, then it definitely does not give you a very comfortable feel when you finish the exam, right? Go back, your one textbook reading will not be sufficient, especially when you go towards your exam. I would appreciate you have to read little bit of textbook, little bit of NCCN, little book of specialized textbooks also will help. This should be the right approach. I would say you start writing notes for all the long cases. Today, you have opened up so many areas by the examiners where you feel little uncomfortable. I could appreciate where are your lacuna. Sit back. You can listen to this presentation. It's going to be on the YouTube forever. Please sit back and identify the area of lacunae and then fresh up those areas. That is all. All of us have come through your stage. So it is nothing wrong. Please go back, see the video again, see the presentation where all you had difficulty. And there have been few comments from the other examiners who are not part of the teaching today that you are running through your presentation rapidly, right? You go a little slow when you present because the examiner has to follow your finding in a logical manner, or else they may end up asking you the question usually that you have told. You should have very clear pauses between findings, either positive or negative, especially positive history and relevant negative history. Let's see, assimilating. Patient gives history of GI bleeding, or patient gives history of melena. Patient gives history of induced vomiting. Patient gives history of induced vomiting. That does not matter. That does not drive the message. Patient gives history of induced vomiting. Then you describe about what is the induced vomiting type this patient is having. Patient gives ball rolling movement. Stop there. Ball rolling movement is present all through the day or on taking food. What brings the ball rolling movement and what relieves the ball rolling movement? So there should be a pause in between your lines that makes the examiner to understand you are confident. Right? So that will be few examiner tips. May I request Dr. Anandi Madam, Ganesh Babu sir, and Abhay sir, and G. Prakash sir to give the closing remarks before we go to the next case.
Thank you, Kanakavel. I'm audible?
Yes, sir. Very well, sir.
Yeah. I went through the discussion part. Dr. Visha done very well in the theoretical discussion part. At the very early said, there are a lot of lacunae in the clinical history taking. He has not mentioned points about early satiety, which is the disease symptom, which for the coming to diagnosis of malignancy. Coming to the clinical diagnosis, stuck only the malignancy part, though the lump is huge in size, is unlikely to have a cholesterol of stomach present such a vast size of the lump. He should have considered that differential diagnosis. And coming to findings, he's not mentioned anything about the VGP, which type, and he's not very clear about. I didn't follow what the description about a suction splash. It's difficult to accept such huge lump producing a suction splash. So these are the few lacunae presentation. The rest of the findings, fine, okay.
Thank you.
Veer, please.
Veer,
yes,
your presentation was very good and you are prepared well. Only thing is you are so hurry and you are listening to the examiner so keenly. If you listen what really they want, probably you will be able to answer all. I feel that you have read a lot and you know answers. You are in a hurry to answer immediately. Don't try to answer like a robot. Just once you receive questions, don't answer immediately. Wait, sit and just think for 2-3 seconds, then revert back. That will be the best thing for you to come out of exam without any issue. All the best.
Thank you, sir.
Thank you. Madam.
Visha, can you hear me?
Yes, ma'am.
Yeah, I think you did a good job of presenting well. I was not there when you were presenting. I heard from others that you went through a rapid phase, but otherwise you answered the questions, everything pretty good. Remember that in a case of a CS stomach, usually the presentation would be either as a mass or it might be as a metastatic symptoms or with a outlet obstruction. These are the three things usually they will present us. When there is going to be a metastatic thing, you think the patient treatment is going to be palliation. Okay. If it's not going to be metastatic, then you can go ahead and think about whether it's going to have any other addition and other things, and then you can go ahead and do the surgery. That is the main thing you have to remember. When there is a metastasis, you think about palliation. When there's going to be an involvement of the adjacent structures, think about of neoadjuvant chemotherapy and then going for surgery. So these two things you have to keep in your mind. Otherwise, it was a good presentation, and I enjoyed everybody's questioning. And thank you, Kanagavel.
Thank you, ma'am.
Dr. Jayalal, sir, please.
I was just watching this, but it is excellent. The candidate is relatively presenting well. The findings are very good, but he needs to study little what is updated. When they, what is the, even like drop metastasis and the transulumic metastasis, they are not now almost outdated. Even for Kurkenberg tumor, it is the lymphatic spread is much more importantly they are giving, and not the things. And Kanagavel has very rightly pointed out about the cytology, and when the cytology is not going to determine the or adopt a treatment based on if it is no macroscopic finding is there. But it is a very good constellation of ideas which come from especially Abhay Dalvi sir as very, very pungent in asking these questions, and I am sure that it's very, it will motivate the students to look for the very practical tips in when they are coming out with the presenting the cases, and that always delineate whether they are working in the ward or not. It is a very good effort which Kanagavel sir is doing, and we congratulate the candidate and all the faculties for an excellent coordination of this.
Thank you, sir. Andariya, sir, you give your closing remarks before we move to the next case.
I think I have told Veer many times that he has to listen to the question. He has to understand what examiner is expecting, and he has to lead the examiner the way he knows the subject, not the other way around. Say, for example, he's starting with some uncommon causes, so where he can be trapped. He obviously knows what he knows. Examiner smarter, right? Dalvi sir, like examiner will ask you the question what you are trying to show. So make sure your answering is justifiable, rational, and related to the common causes.
Finally, remarks you can.
Yes, thank you, sir.
Pertaining to the cases.
Thank you so much, sir. Vivekanand Subramanian, your final words, please.
Yes, sir. Thank you very much for all the faculties. Sir, Dr. Vishwa, you have done well, but one thing, in the examination, you have to slowly present. Don't fast. Your presentation good, answer is good. Better give the answer to the questions. Unnecessary, don't give a chance to the examiners. So this is for a related to the examination point of view. Anyway, you have done well. Thank you.
Thank you, Dr. Isha. Can you please mute yourself? Now we move on to the case.
Yeah. Next case.
One senior.
1.5 hours over.
Yes, sir. One senior professor by name Rupkumar Karabadi is there with us in the line. Sir, can you please identify yourself? I'm not sure which college you are from, sir. Professor Rupkumar? Okay, fine. He is not with us. Sir, Abhay Dalvi, sir, can we move to the next case?
Yeah, please.
Meera, Dr. Meera?
Yes, sure, sir. Shall I start, sir?
Please
yeah, you can start, please.
Good evening, sir. I'm Dr. Meera K from Ramaya Medical College. I'm going to present the case of Mrs. Rana Bala Chakrabarti, a 63-year-old female hailing from West Bengal, housewife, belonging to low socioeconomic status, came with the chief complaints of yellowish discoloration of urine and eyes since 2 months, complaints of pain abdomen since 1.5 months, and nausea and vomiting since 1.5 months. History of presenting NS. The patient was apparently all right 2 months back when she noticed yellowish discoloration of urine and eyes, which was insidious in onset, gradually progressive, not associated with gaining and waxing of jaundice. It was associated with pain abdomen, clay-colored stool, and generalized itching. Patient also gives history of pain in the right upper quadrant of abdomen since 1.5 months, insidious in onset, dull aching type, continuous, mild to moderate in intensity, non-radiating, not referred, no aggravating factors, and relieved on taking oral analgesics. Patient also gives history of nausea and vomiting since 1.5 months. Vomiting is on and off episodes, non-projectile, small quantity, watery gastric content, not blood or bile stain, non-foul smelling, not associated with food intake. However, the nausea is aggravates after taking food. Patient also gives history of dyspepsia since 1 month, loss of appetite, and loss of weight, which she couldn't quantify. However, she says she had significant loosening of clothes. Negative history, no history of hematemesis or melena, no history of fever, no history of previous blood transfusions, no history of drug intake or mass abdomen, no history of altered bowel habits. For the above complaint, she had shown to a local hospital in her village, and she was treated with oral medication. However, the symptoms didn't subside, and she was referred here for further management. Past history, the patient was diagnosed to have diabetes mellitus 2 months back and is on oral hypoglycemic agent for the same. There is no history of any other medical comorbidities, no history of jaundice or biliary colic in the past. Family history, there is no history of history suggestive of any malignancies in the family. Personal history, she has mixed diet, reduced appetite, regular bowel habits, undisturbed sleep, no history of substance abuse, and she attained menopause 15 years back. Coming to examination, she's an elderly female, moderately built, poorly nourished, with BMI of 19.1.
Not audible. I think PPT is not visible on screen. The older PPT is still available. If someone can rectify.
Sir, is it
you please stop sharing and reshare the PowerPoint.
Okay, sir.
Veer, please unshare your PPT.
Sir, is it seen, sir?
Yeah.
Okay, proceed.
Sorry, sir?
You are doing well, doctor. You please proceed with the presentation.
Okay. General physical examination. Elderly female, moderately built, poorly nourished, with a BMI of 19.1 kg per meter square, with ECOG score of 1. She has icterus, deep yellow-green, noted in the sclera, floor of the mouth and abdominal wall.
I think PPT is not visible.
Sir, the PPT is visible to us.
Yeah, it is visible to us.
Let me try.
Yes, sir. Yes, sir. Visible.
Okay, I'll try.
Is it fine, sir?
Yeah, now it's visible.
Yeah.
No signs of dehydration. Scratch marks were noted over legs and forearms. No signs of liver cell failure. Pulse rate of 72 beats per minute, noted in right radial artery. BP of 118 to 78 mmHg in right brachial artery. Patient was afebrile at the time of examination. Coming to per abdominal examination. After taking informed consent, patient was exposed from nipple to mid-thigh. Inspection, abdomen is flat. It is normal in shape and position. All corresponding quadrants move equally with respiration. There is yellowish discoloration noted over the anterior abdominal wall. There is no scars, visible veins or visible gastric peristalsis, no pulsations. Flanks are not full. Renal angles are normal. No, all hernial orifices are normal, and left supraclavicular fossa is normal. Patient, there is tenderness noted in the right hypochondriac region and epigastrium on deep palpation. 3 into 3 centimeter globular mass is noted in the right hypochondrium. All borders are well made out except the superior border, wherein the fingers cannot be insinuated below the costal margin. The surface is smooth, consistency is firm. The swelling moves with respiration, and there is side-to-side mobility. The plane of the swelling is intra-abdominal, intraperitoneal, likely gallbladder. Lower border of liver is palpable 1 centimeter below the costal margin on deep inspiration. There is no splenomegaly. No other mass palpable. Bilateral renal angle, no mass palpable, no tenderness. Supraclavicular fossa, no swellings, no. Percussion, liver span is 15 centimeter from the 5th intercostal space in mid-clavicular line. Gallbladder note is different from that of the liver note. No free fluid noted. Auscultation, normal bowel sounds heard and no buoys were noted. Per vaginal examination was normal. Per rectal examination, normal, no Bogginus felt, no Lammer shell felt. Respiratory system, bilateral normal vesicular breath sounds heard, no evidence of pleural effusion. So cardiovascular system, S1 and S2 heard, and CNS normal higher mental function. Coming to differential diagnosis, obstructive jaundice, probably secondary to the carcinoma head of pancreas, cholangiocarcinoma. Bilateral normal vesicular breath sounds heard, no evidence of pleural effusion. Cardiovascular system, S1 and S2 heard.
Some unnecessary sounds.
Obstructive jaundice, the carcinoma head of pancreas, cholangiocarcinoma.
Please proceed, doctor.
Okay, we will discuss with the history first.
Yes.
You said the patient had a weight loss. What do you
Yes.
mean by a significant weight loss?
10% weight reduction in the weight in 6 months.
Anything more to be added to this? It's not only 10% of the weight loss in the preceding 6 months. It is and it should be an unintentional weight loss.
Yes.
Okay. So that is the important thing. The person is going to be having a weight loss because of an intentional one. Then it doesn't come under a significant weight loss. Okay. And you said the patient had a sleep pattern. What was the sleep pattern you expected in this patient?
If the patient had severe pain, the sleep would have been disturbed, but she has mild pain which subsides on taking oral analgesics. So the pain is not that severe in this case.
Okay. So the sleep pattern, it may not be altered only because of the pain. Okay. The sleep pattern can get reversed. Patient can have a daytime sleepiness whenever there's going to be a liver cell failure.
Yes.
Right. And what was the pulse rate in this patient?
And pulse rate was 78 beats per minute.
Okay. So what change do you expect in a person with a jaundice in the pulse rate?
Patient might have tachycardia.
Tachycardia. Why?
If the patient had associated fever with it, we can suspect of cholangitis.
Only talking about liver cell failure when the liver is impaired. It will be bradycardia.
So there will be relative bradycardia. Okay. This relative bradycardia, why do you have this? It is because of the bile salts which are going to be deposited over the sinoatrial node. You tend to have a relative bradycardia. Okay.
You said there is an itching in the legs and forearm.
Yes.
Is it significant? Is a diabetic fellow, the old man, diabetic, when there is an itching in the periphery, is it significant of an obstructive jaundice, or why do you get a jaundice? Itching you are expecting?
So mainly, she had itching in the periphery, sir.
Periphery? Is centripetal or centrifugal?
In the arms and limbs, both the limbs she had, sir.
When an old man with a diabetic come with the itching in the arms, we will not consider as an obstructive jaundice as a first cause. There are so many other skin diseases. It is now only it is centripetal and it should be in the abdomen or if you that is possible. Why do you get itching?
Sir, sorry, sir.
Why do you get itching?
Due to deposition of bile salts in the subdermal dermis and activation of the mast cell to release histamine.
The color of the stool is clay. What is the color, clay color in your area? What is the color of the clay in your area?
It's pale colored, pale stool, sir.
You must, you are using the word clay, and you must be very careful because the clay is not pale in color. So it must be, the history must be the change in color, or if there is a change in the alteration, the color becoming a pale, and that is more significant on that. You said both jaundice and discoloration of the urine was noted 1.5 months back. Both occur simultaneously.
Sorry, sir.
When in the symptoms, which will occur first in the case of obstructive jaundice? You get a jaundice first, or you get an
The first jaundice will happen.
discoloration of the urine?
Sorry, sir, it's not. Yes, sir.
Okay. What is the difference between hyperbilirubinemia and jaundice? Hyperbilirubinemia and jaundice both are same or different?
The hyperbilirubinemia is more than 1.2 mg per deciliter. If the serum albumin bilirubin level is more, then it is hyperbilirubinemia. Whereas for jaundice to occur, the bilirubin level should be more than 2 to 2.5 mg per deciliter.
Now you asked the history of waxing and waning, but your total history duration of the history is only 1.5 months. What is the normal duration you expect for the waxing and waning to take place? Suppose there is the history only 2 weeks, 1 month. Do you expect there is a waxing and waning?
The tumor should grow to a
question. Waxing and waning. Waxing and waning.
ఎవరు మాట్లాడుతున్నారు ఇప్పుడు?
No, actually, you are able to.
Hello.
Other reasons where you get a waxing and waning.
Sir, we will get waxing and waning even in CBD stones, sir.
What type of CBD stone? What type of CBD stones? All CBD stones?
Yes, sir. Once the stone passes down,
Yeah, slipping stone, slip drop stone.
Yes.
Slip drop stone. What are the condition? What else?
Periampullary carcinoma.
Why periampullary carcinoma?
There is necrosis. When the tumor grows in size, there is central necrosis and sloughing will happen.
Why is that a necrosis?
Because the blood supply is not, the central area will not get sufficient blood supply. So there will be necrosis.
What is the size of the periampullary carcinoma when it start necrosing? What is the probable size of the malignancy?
Slipping stone, slip drop stone.
So it is 2.5 centimeter. So up to 2 centimeter, the blood supply does occurs. When it goes beyond 2.5 centimeter, the blood supply will be decreased. Then start necrosing and sloughing off. So what is the third condition? What is the third condition where you get the waxing waning jaundice? One is that periampullary, second is slip drop stone, slip drop CBD stone.
Primary sclerosing cholangitis, we can get intermittent jaundice.
No. Primary sclerosis is a continuous progressive disease. What is other? Some worms can have positive forms. Positive forms can also do this. Yeah, can once the process passes off, they can have waxing waning jaundice.
Yes, sir.
Okay, continue.
I'll go to the management.
Coming to examination.
Examination.
You said one side you said palpation. Gallbladder is palpable on deep palpation. You expect the gallbladder to palpable on a deep palpation.
So liver is palpable on deep palpation. Gallbladder is palpable.
So when you were presenting, you said on deep palpation there is a 3 into 3 centimeter mass is palpable. So that's one thing. Second, and when you are doing a percussion also, you said on the gallbladder it was superficial. I mean, it is impaired, and so now you are able to differentiate between a gallbladder and a mass. Is it a gallbladder mass?
Sir, what I felt was the note of the hepatomegaly is different from that of the gallbladder that I felt.
The note.
The percussion note was different.
That is true, but you said it is over the gallbladder. Initially, you said it is a mass.
Sir?
The mass or a gallbladder?
It is a globular mass, so likely gallbladder, because it is in the right hypochondrium, all the borders are made out, superior border is not made out, and moves with respiration. Consistency, it's firm, and side-to-side mobility is also there.
Oh, Meera, you are not able to understand what sir is asking. Sir is asking whether distended gallbladder which you are palpating or a mass.
Distended gallbladder, sir.
Okay.
Mira, what else can be mistaken like for distant gallbladder apart from gallbladder? Similar findings, what are other conditions where you can get exactly like similar condition like gallbladder? Any idea?
Riddles.
Yeah, fantastic. Riddle slope, Paulville riddle slope mimics like gallbladder.
Yes.
Yeah, good. And you said there's no splenomegaly. I strongly object for it because you can't say there's no splenomegaly in clinical examination. You can only say there's no spleen is not clinically palpable. But it needs 4 times for the normal size of the spleen to get clinically palpable. So your word is no splenomegaly is not acceptable.
Okay, sir.
Yeah, please continue.
Meera, I have got a very simple question for you.
Yes, sir.
When you say waxing and waning, what are the questions that you ask the patient?
Sir, whether the jaundice patient initially had jaundice and then it reduced, and then again
How does the patient know that the jaundice is reduced?
The intensity of the yellowish discoloration reduces, sir.
No. That's not right. You have to answer the question. Dr. Abhay Dalvi is very clear and asking what history you take from the patient. Patient doesn't know jaundice come down or not. But the sense of well-being is present in patient's history. That you should try to elicit. That is more important.
Maybe itching and all will come down.
Yeah, sense of well-being rather. Sense of well-being. Patient feels comfortable. Patient suffering has come down. Pain has come down. It feels increased, appetite has increased. That's what is the main important point.
Exactly.
Am I correct, Dr. Abhay, sir?
Yes, absolutely. See, when the jaundice is the patient starts feeling better, it is not necessary that the patient visibly sees decrease in jaundice.
And one more thing, when there is going to be a waxing and waning of a jaundice, what is the other history you're supposed to elicit along with this?
Any history of biliary colic in the past?
It is a melena. It is a melena what you're supposed to ask.
What is the difference between colicky pain and throbbing pain?
Colicky pain is intermittent pain. It is due to the tubular structures, sir. And throbbing pain is more because of vascular inflammation. In that situation, you get throbbing kind of pain.
No, come again. What is throbbing?
Throbbing is because of inflammation, abscess, because of vascular.
Vascular?
Because of inflammation, sir. Plus inflammation, abscess.
Throbbing, you get throbbing pain in an abscess.
Abscess, yes.
Why?
You get that.
Why?
Why?
Something stretches there.
Correct.
Something
It's
stretches.
not inflammation. It is an expansion.
Expansion. Stretching. I've given the clue to you.
Define an abscess.
Got the basics. Yes.
Abscess is
yes.
of dead necrotic tissue with neutrophils.
Collection of pus in a enclosed
space.
There is a capsule. Now, if it stretches, you start getting throbbing pain. Just to deviate, means I know you must have read a lot of obstructive jaundice, but you must have even basically drained more abscesses. So I want to know whether you
abscess only dead tissues.
Sorry, sir.
You said abscess has a dead tissues. Is it only abscess will have a dead tissue? Is there,
no, sir,
there be any living tissues?
Neutrophils will be there, sir, and microorganisms.
Microorganisms will be there. Okay.
Does not matter, Meera. Let's come to your diagnosis of obstructive jaundice. How will you go about investigating?
So first, to confirm obstructive jaundice, we'll get liver function test done.
When you ask for liver function test and when the report comes in your hand,
yes, sir.
Tell me what are the things that are there in the report that you would like to tell me?
So first, I would like to see the total bilirubin and the direct bilirubin.
Okay.
If the direct bilirubin value is
Wait. What is my question? What are the things
what
that
all will you see?
Now, if you are going to start telling me if direct is more, etc., you are inviting me.
Yes.
Don't invite me. You tell what I have asked.
Total bilirubin, direct bilirubin. Then I'll be looking at the alkaline phosphatase level and protein for the nourishment of the patient, sir. Protein and albumin level for the nourishment of the patient. Transaminases will be moderately elevated.
Albumin level for the nourishment of the patient or anything else?
And the liver function, sir. Liver secretory function.
Okay. Okay. Let's
in thousands.
Sorry, sir.
If your enzymes and SPT are in thousands,
yes,
are you
sir.
concerned with this or you're okay with this?
AST, ALT are in thousands, sir.
Yes.
Some liver pathology, underlying liver pathology will be there if they are elevated.
Anything like cholangitis or dealing with a separate system, infection of the biliary tree, what will be the manifestation of that in the liver function test?
If there is obstruction, ALP will be increased, sir. And AST, ALT will be increased if there is any hepatitis. It
okay,
shows.
Please move ahead.
You are on the right track. Destruction of hepatocytes equal to enzyme rise. That is what you should answer.
Yes.
Okay. So let's say bilirubin is 10, direct is 10.5.
Yes, sir.
SGPT is little bit raised. Alkaline phosphatase raised, DGT is raised. PTINR is what would
PTINR, sir?
PTINR is normal. Prothrombin
yes, sir.
are normal.
Yes,
now,
sir. Yes,
what
sir.
is the next thing that you would like?
Next, I would like to investigate the mass that is there.
So go ahead, investigate.
I will like to get the ultrasound abdomen done, sir.
So tell me what the question which I had asked the previous candidate, I am asking you. When you are asked this question,
yes, sir.
When you are going to answer ultrasound, tell me what information ultrasound is likely to give you vis-a-vis the examination findings.
Sir, ultrasound will tell us if the mass that is first, it will tell us about the mass, whether the mass is gallbladder or not. And it will tell us about the extrahepatic biliary radical dilatation and intrahepatic biliary radical dilatation. And it can also assess pancreas at the same time.
Fair enough. Anything else that you are going to ask the sonologist to tell you to look for? Your diagnosis is lower end malignancy.
Yes, sir.
Somewhere around the ampulla of Vater.
Yes, sir.
So, you know that you are dealing with malignancy. You have asked for sonography.
Yes, sir.
For you may not be able to see the tumor. Fine. You have answered properly extrahepatic, intrahepatic biliary radical dilatation. You have said distension of the gallbladder. Anything else you want to know?
Yes, sir. Hepatomegaly, if it is there.
Very good.
Then ascites, if ascites is present or not. Free fluid.
Nice. Mira, you have to be very clear in your mind.
Stones in the CBD.
Indirectly, what I'm trying to ask you is whether there is spread of disease, which can be made out on ultrasound. So local pathology, then effect of the pathology, that is dilatation of the biliary tree and distension of the gallbladder, and then hepatomegaly, then the spread of disease. How does malignancy spread? How does a lower end malignancy spread?
lymph nodal metastasis, and through the submucosal plane it will go up.
Will lymph nodes be affected?
Hello.
Which lymph node will you look for? Or tell the sonologist?
Sir, hepatoduodenal lymph nodes are the first lymph nodes that are involved. After that, we'll have the periportal lymph nodes and the retropancreatic lymph nodes.
Also, you can make out on sonology, right?
Yes, sir.
Okay. Now, sonologist has given you report. No nodes. Dilatation of intrahepatic biliary tree is there. Extrahepatic biliary dilatation right up to the duodenum is there.
Yes, sir.
Gallbladder is there. Otherwise, it is nothing.
Sir, I would like to do CCT abdomen and pelvis.
Go ahead.
I like to do CCT abdomen and pelvis. It will tell better about better information about the lymph node status, and it will also give us information about the vascular structures are involved or not, and the proper extent of the tumor will also be delineated.
Which vessels do you think are involved in the distal malignancy?
Sir, if it is superior mesenteric vein, portal vein, and gastroduodenal vein artery can be involved.
How do you make out gastroduodenal vein on CT scan?
We can.
Huh? Then why? Again, I'm catching you. You are getting more information than required. So supramesenteric vein is not involved. Vein is not involved. Now what? Ripples?
No, sir.
Then?
No, it's okay.
What else? Come
on. The extent of the tumor.
You have not yet reached the diagnosis only.
And pipes.
You have not reached the diagnosis. Now, I appreciate your clinical knowledge. But then as a patient, I am going to ask you, मेरा इतना बड़ा operation करने वाले हो, you are operating on me, such a big operation. Where is the diagnosis?
We can do an MRCP to delineate the...
That will not be diagnosis.
Better diagnosis.
Help me. Somebody please help.
No, what is better diagnosis? Investigative modality to confirm a diagnosis.
ERCP and biopsy can be taken if it is this lower end.
Suppose it is not showing mass, still you want a biopsy. What can you do?
ERCP and breast cytology.
That is inconclusive. You don't see mass on CT. You are
EUS and then we can do an FNAC from if at all we find any lesion.
Yes.
From Meera, the guidelines.
Is there tumor markers available? Any tumor markers? Any tumor markers?
The CA19-9 carbohydrate.
That can help you out some extent.
The CA19-9 can be.
But it is not specific to malignancy.
It's not specific, but guides you.
So
in addition, helps you to guide you EUS, then FNAC.
Yes, sir.
Dr. Meera, the point that Abhay sir wanted is the patient is going to ask you, you are planning for a 5-6 hour of operation involving multiple anastomosis, and you are telling you have chance of very high complication after the surgery.
Yes, sir.
Do I have a confirmation of the pathology? The current guidelines are.
Other thing is, sorry for interrupting.
Yes, sir. Yes, sir.
Is it must to have a histopathology for going ahead with for your probably the procedure of surgery? Is it a must? What is latest guidelines? What Anakavel is trying to put.
If it is palliative, then we need a tissue diagnosis. Otherwise, we can go ahead with the surgery and
The point is now the era of pancreatic surgery is heading towards neoadjuvant downstaging therapies. Number one, especially your radiology evidence is not suggesting that you may end up having a R0 resection.
Yes.
Or if the tumor is attempting to invade into the vascular structure,
yes,
then you definitely there is a benefit of the neoadjuvant therapy. If you are
yes.
planning for a neoadjuvant therapy, biopsy either in the form of cytology,
Yes, sir.
ideally differentiation status also should be known. The invasive status of the tumor are also to be known to plan for a neoadjuvant therapy.
Yes.
At this point, neoadjuvant therapy obviously means gemcitabine based monotherapies or gemcitabine and taxane based polytherapy. Let's stop there with that. We are not going to oncology part of it. Number two, if you have a 1 centimeter sized lesion, either it can be a common bile duct, it can be an ampullary or a head tumor, less than 1 centimeter size lesion, whatever be the modality you do, may be a challenge for establishing the histology. Number three, at times, biliary tumors can present with only as a malignant stricture. You don't see a mass at all. Then you may technically not be able to establish. You may tell it is positive for malignancy or negative for malignancy, and you have a very high risk of your ERCP procedure or endoscopic ultrasound guided procedure to become negative. All right. So the examiners want to know, are you aware of the recent advance, something called spyglass? Spyglass is the one system to ERCP. You are able to see the lumen of the bile duct, where you will be able to physically take a biopsy under vision. Because when you do a EUS, it is a endo image, like I would say shadow-based guided FNAC, very precise. But the most precise common bile duct tissue access is at this point of time is a spyglass. At this point of time, the third issue what we should be well aware is, if the tumor is primarily resectable, if you are confident that you are going to do a R0 resection in presence of dilated biliary tree, it is worthwhile considering a Whipple's pancreaticoduodenectomy, provided patient's performance status is good enough for holding such a long surgery. This is all you have to tell. You don't need a clear-cut preoperative histology for deciding these patients. All right. As you rightly said, if you're doing only a palliative procedure, the biopsy can be preoperative. See, if it is a huge mass in the head of pancreas causing duodenal obstruction, going in for a sake of diversion, you'll be able to take some amount of tissue. Possible. Sometimes you may still have challenge of taking a biopsy. Please be armed with a true-cut biopsy for taking a tissue for your confirmation. Because patient may say, you have done a bypass only for a chronic mass-forming pancreatitis. What biopsy evidence to tell? Because the oncologist will be very particular. Unless you are going to give them a tissue diagnosis of what cytology or what histology you are going to do, they will not be able to do. The perioperative biopsy is itself a short note question for you. So be prepared with that. The NCCN guidelines give very clear approach to this. All right. Now,
yes.
let the faculty take over the other things, because the PG should be aware of what is happening on the biopsy per se. All right. May I request the faculty to take over, please? Okay, Samir.
Sir, Samir.
Yeah. You've been always quite.
See, you did endoscopy, you did the biopsy. This patient bilirubin is 10.
Yes, sir.
What to do next? Because Dr. Robert Albisar said this bilirubin is 10.
Yes, sir. We can, since bilirubin.
Yeah, continue.
Since bilirubin is 10, we can see the nutritional status of the patient and then counsel the patient for the surgery.
What about why 10? Suppose what about is 20?
I think you should understand the question about Samir, whether the patient requires drainage, preoperative drainage or not. If what is the reason, what is the indications, what is the limitation, bilirubin levels to drain or not to drain. Is there any, what is the latest school of thought? That's what he wants to know.
Sir, if we do pre-op endoscope, ERCP and stenting, there are more chances of introduction of microbes and post-operative complications of infection. If the patient's nutritional status is good and the patient is not if the patient's nutritional status is good, we can, even if it is 10, we can proceed with the surgery.
We can proceed, but if it is 20?
Meera, I am asking you a simple question here. The issue is whether preoperative stenting or preoperative drainage or no. WBC count is 18,000. Now what will you do?
Drain or no drain?
We have to drain.
So not only nutritional condition, but also you want to rule out cholangitis patient. And even if the patient is asymptomatic, you can whether there is an occult cholangitis in this patient or no. High bilirubin is not a contraindication for going ahead without him.
Yes, sir.
Clear?
Yes, sir.
What is the effect of high bilirubin when you are operating? What is the precautions you will take? Bilirubin is more than 20. What are the complications you will expect? The acute tubular necrosis of the kidney is one of the major complications with that. You must be extremely cautious on that. Suppose you do not have a ERCP, is there any other way of drainage?
Percutaneous transhepatic decompression.
What is double duct sign on a CT scan?
So there will be a dilatation of the pancreatic duct and the distal CBD, sir, due to obstruction.
Now, if the CT reports to you that pancreas looks normal,
yes,
and
sir,
CT reports to you that there is evidence of chronic pancreatitis also in presence of malignancy, the surgeon, which of the chronic pancreatitis will be happy or a normal pancreas will be happy?
Sir, chronic pancreatitis, if the patient has, there will be pancreatic insufficiency. So once surgery is done, chances of more complications. Whereas if pancreas is good, preserved.
Have you seen a pancreatic duodenectomy?
Yes, sir.
Have you seen pancreas being anastomosed to the intestine or the stomach?
Intestine, yes, sir.
You have seen, right?
Yes, sir.
Okay. Tell me how easy it is to do the anastomosis in a normal pancreas and a firm pancreas.
So there will, if the pancreas is soft and fragile, it will be difficult.
So that's why I asked you. There is chronic pancreatitis and there is a normal pancreas. Which patient you are happier as a surgeon?
Chronic pancreatitis.
Thank you very much. My question is logical and simple.
Suppose the blood level shows the serum albumin is 2.
Yes, sir.
What you will do?
So we have to increase the nutrition. We can we have to feed give enteral feedings to the patient.
How long it takes time to it is recover?
Minimum 2 weeks.
6 weeks. Is there any role of albumin which you are giving?
It will only increase the extra vascular volume. It will increase. It won't increase the protein content of the body.
No evidence to say that extra albumin which you are giving is important, and you have to only enough time to for the liver to recover.
Yes.
Let me take you away from malignancy of the lower end of. Tell me all complications caused by gallstones.
All complication caused
Gallstone.
Gallstone complication. One is acute calculus cholecystitis, Lima gallbladder, then mucosal of the gallbladder, if it is stuck at the level of the neck of the gallbladder, then it can flow down.
Empyema also it is stuck at the neck.
Yes.
Which comes first, mucosal or empyema?
Mucosal, sir. Mucosal.
And why you told me empyema before mucosal?
Then CBD stones.
No. Be very clear. Causing problems in the gallbladder, gallstones causing problems in the common bladder. You have not yet finished gallbladder. The stone remains impacted.
It can go and get impacted near the heart-rate pouch and then compress on the CHD.
I am still talking about gallbladder. You told me mucosal, you told me gangrene.
Gangrenous gallbladder. Emphysematous gangrenous gallbladder.
What is mucosal, by the way? What is mucosal of gallbladder?
Because of obstruction, the mucus secreted will be collected and the gallbladder will be discharged.
When the obstruction out of the bile enters the gallbladder.
Sorry, sir?
When a stone obstructs out of the bile enters the gallbladder.
It is just the mucus that is there, sir. Secretions of the gallbladder itself.
Very good, very good.
You have mucosal, then you have empyema of the gallbladder. It keeps on distending. Can give perforation. It can be perforation. It can be localized or it can be generalized. And if nothing of that sort happens and the patient starts becoming all right, patient develops chronic cholecystitis. And if the stone keeps on remaining there in the gallbladder, slowly goes into one of the hollow viscous, usually what condition? If it goes into a hollow viscous, especially the duodenum, and large stone enters the intestine, what condition the patient presents with?
Paralytic gallstone ileus.
Gallstone ileus. So these are all that, and last but not the least, is malignant. And now you tell me, stone starts pressing on the common bile duct, is give rise to jaundice. What is that condition known as?
Mirizi syndrome.
Mirizi syndrome. I'm not going to ask you types of Mirizis because I know that you have read.
What is Kurvaisius law?
In a jaundice patient, palpable gallbladder is.
No, wait, Meera, wait. Either causes jaundice or it causes small stone.
Gallbladder.
Small stone slips into the common bile duct.
It will cause colicky pain and obstructive jaundice.
Biliary pancreatitis?
Somebody shouting. Pancreatitis.
Yes, sir.
So these are many symptoms and complications of gallstones.
Yes, sir.
Okay. Yes. The types of gallstones.
Sorry, sir.
Types of gallstones.
Pigmented gallstones, cholesterol gallstones, mixed gallstones.
Come again.
Commoner first.
Cholesterol gallstones, pigmented and mixed.
What is characteristic of cholesterol stone? I will not say stones. I will say stone.
It will be hexagonal shaped and brownish yellow in color.
Can you comment about the numbers and the color of the cholesterol stone?
It will be solitary and it will be proper shape, will like hexagonal or pentagonal shape.
What is a sludge? What is
sludge? Is it is bile.
Are the patients which develop acute cholecystitis are likely to go?
Sorry, sir.
Which are the patients in which can develop acute cholecystitis are more prone to gangrene?
Diabetics.
Very good. Diabetic patients. And obviously they don't have any symptoms. They may not have even pain. Why? Why?
Neuropathy.
Very good. Neuropathy. You are good, huh? Really good. But you are still holding on quite well.
Yes, sir.
Let's come back to Whipple's. Let's come back to Whipple's. Now we'll go into theory.
Yes.
I mean,
you prefer?
Suppose it's INR shows 2.3.
Okay.
Yes,
How
sir.
you are going to manage? Your INR value is high.
Sir, yes, sir. Initially, we will give vitamin K injection for 3 days, 10 mg.
Why do you want to give vitamin K?
Sorry, sir.
Why do you want to give vitamin K?
Sir, in jaundice, fat soluble vitamins are not absorbed. That is ADEK. So, and prothrombin synthesis is also reduced. So, we give vitamin K, which is required for these factors.
Obstructive jaundice, vitamin K is not absorbed. Where the vitamin K is absorbed?
Sir?
Where is the vitamin K is absorbed?
Intestine.
Intestine is a long area.
Ileum, sir.
Huh?
Ileum.
Where in the ileum, where are the upper end of the
Ileum.
the deconjugation of the bacteria is not happening in place. So, can you give a oral vitamin K?
It won't be useful, sir, because again it requires fat for absorption.
In obstructive jaundice, vitamin K will not be absorbed because the enterohepatic circulation is not taking place adequately. That is why in a neonate also you give. Where there is no adequate bacteria is there, you are giving. So, at what level of INR you will start treating?
So, if it is more than 2.
More than 2. What is the normal normal values?
1 to 2. 1 less than 1 is the normal value.
Oh. Anything more than that of 30%, and we need to start to. And how many doses of injection?
10 mg IM OD for 3 days, sir.
What is INR? What is INR?
International normalized ratio, sir. It is.
So it's a ratio, right?
Yes, sir.
So 1, 2, 3, 4, 5 INR. What is ratio with?
Sorry, sir.
Is it a ratio with what?
PT, sir. Control and patient speed. Prothrombin time.
Correct.
That area. Okay. Very good.
So let's come back to Whipple's. You want to discuss Whipple's, na? So tell me, in what circumstances you would prefer jejunum or stomach as the organ of anastomosis with the pancreatic duct?
Sir, jejunum.
Jejunum. Fair enough. It's your choice. I'm quite sure Kanak will agree with the latest literature. It depends on what comfortable you are. What did you watch when anastomosis was done?
So it is duct to mucosa anastomosis that is done.
Yes. Suture material, come back to the same questions. Suture material used.
Vicryl, sir.
Really?
What zero?
Really?
I'm not sure, sir.
Vicryl, that pancreatic juice will digest it immediately.
Better options?
TDS.
Or
proline.
Will you like to stent it?
Yes, sir. If it is less than 5 mm, we have to stent, sir.
Very good. And what zero material? You did not tell me. I'm asking you this because you said you have assisted.
Suture size. Yes, it is very important.
30, sir. I'm not sure.
You are not. Okay, does not matter. Round body or cutting needle?
Round body, sir.
Round body. Everybody now knows what I'm going to ask. That's the
size of needle.
What stent will you use in case you think of stenting it?
Huh?
What stent you will use?
Or what can you use?
Plastic stents.
What is available for you to use?
Tell the sister, give me this.
You cannot say plastic material.
Something to do with infants.
Infant feeding tube.
Thank you very much.
What will happen to the stent?
We have.
You have kept the stent.
Would you like to fix it with one of the sutures, or you will just?
Sorry, sir, I didn't get, sir.
Will you like to fix it with one of the sutures, or will you like to keep it as it is?
We'll keep it as it is, sir. We'll remove.
Then it will slip off. That is why I asked you what will happen to stent.
It comes out naturally.
Okay.
You want to just slip it up.
Meera, you have managed these patients post Whipple's in the ward?
Yes, sir.
Okay. What specifically investigation do you do to know whether there is a pancreatic anastomotic leak?
Sir, brain fluid serum amylase we have to take and send it, and
that is not serum amylase.
Fluid amylase.
Brain amylase we have to take and send it, and if it is more than 3 times the serum amylase, then pancreatic leak is there.
No. What if it is pancreatic leak? How much a range? How much amount do you expect? Suppose it is one, say 400, 500 international units. Will it be pancreatic leak?
Sir,
if it is pancreatic,
What is the question, sir?
If it is pancreatic leak, how much will be the reading of fluid amylase? In thousands.
3 times the serum amylase values.
No, it is in thousands.
So classify pancreatic leak following Whipple. And then
grade A, B, and C.
Go ahead. Anagwell is nodding his head. Yes.
And not interrupting us.
See, when you are asked these questions, take it from me, you have already passed.
Yes.
That's for sure. These sort of questions, people don't reach at all. So once you reach a level of discussion of complications of a major operation, you should be confident that you are passed. Now you have 2 options.
Yes.
You know or you don't know. Quickly say don't know and get out, till you will pass. Otherwise, if you know, you talk.
Higher questions of kaun banega crorepati.
You have to take a decision whether to conserve this patient or not to conserve this. It's a very vital decision for a surgeon to take in a post-operative situation.
Yes, sir.
When do you think you will conserve this patient to what level? No, I have to go in. After going in, what is done, God knows.
I didn't get the question, sir.
See, whenever there is a pancreatic leak, pancreaticosteotomy leak following a Whipple's operation,
yes, sir,
the surgeon has to take a decision whether conservative modality of treatment is to be taken or operative modality. So,
yes, sir,
what determines you to decide I should operate on this patient or I should conserve this patient?
So if the output is persistently high, and if the patient requires readmission, and for
inpatient only.
We have never discharged the patient.
Okay. If the leak is persistent for more than 3 weeks, if it is persistent and the quantity is high and it's affecting the nourishment of the patient, we have to intervene.
What medicines or drugs may help in reducing the incidence of leak or contain the leak?
Octreotide can help, sir. Somatostatin.
Dose.
50 to 200 micrograms subcutaneous. We have to give 8 hourly.
Perfect. Sorry to disturb you, sir. Dr. Meera, please, in consideration with the question Professor Dalvi asked, what are the indication for reoperation following a high drain output? Number 1, is increasing by the day. Number 2, if you have enteral content, enteral in the sense you get to see bile, you get to see the bowel content in the drain, yes, it becomes a priority to enter. You see blood in the drain, fresh blood in the drain, it becomes a point to again re-enter. Again, there is a way how you restore, which also helps you to do. Dr. Abhay sir was repeatedly asking you what type of anastomosis you are familiar, because that is the one which is going to govern. See, if you have done a white type of anastomosis with dunk of the distal pancreas, little bit of amylase leak or little bit of pancreatic leak, you tend to wait. But if you have done a pancreatic or gastrostomy and you have a leak, then the indication to enter is much earlier, right? The POPF, the Atlanta guidelines have come very recently. Last year it has come, it is open access. Re-entry guidelines following a high pancreatic postoperative fistula is a separate question for you, right? So you should be aware there are some indications which can be managed with endotherapy, or a guided aspiration also is possible. Restoration by way of a pancreaticojejunostomy and gastrojejunectomy gives you more leverage, or you can wait little longer. If you have done a gastrostomy, your re-entry threshold has to be much lower, right? And there are many indications apart from your increasing fluid alone. The most important thing is when you have half a liter of fluid output with amylase of 10 or 20, that is not an indication for you to go in.
Yes, sir.
Please understand, drain fluid amylase and the volume and the type of fluid drives you to re-enter. All right. Thank you.
Yes, sir.
I feel like giving you distinction, Meera. So you have to answer my 3 questions.
Yes, sir.
What is Whipple operation?
Sir?
You have to answer 3 questions.
Yes, sir.
What is stand first?
Yes, sir.
What is Whipple operation?
Yes,
What
sir.
is Whipple disease? And what is Whipple triad?
This is a common question they will ask us.
Yes,
I am going to fail. This is my ultimate.
Even after double century, bowler gets the wicket of the batsman, he is happy.
Yeah. See, I am telling you, a lot of my residents are also watching. And I have been all the time telling them that Abhay Dalvi is a very nice examiner to pass. But to give gold medal, he will come out with questions which are going to be really hard. So your homework for today is go back and read what is Whipple's disease.
Yes, sir.
What is Whipple's triad,
Yes,
and what is Whipple operation. Because
Yes.
you have reached that level of questioning. So when you study so much better to just quickly see what is Whipple, because my next question would have been what is Whipple's first name. So that's okay. All the best to you.
Thank you, sir.
One technical question I like to ask.
Yes, sir.
You have done a resectability, operability section by dissecting the following middle colic vein and supramesenteric vein, and you have made that tunnel. Are
Yes,
you
sir.
sure that the disease is resectable or operable 100% in periampullary tumor?
On table only we'll come to
No,
this.
on table. You
Yes,
have
sir.
made a tunnel. You have made a tunnel behind the neck of
Yes, sir.
pancreas, anterior
Yes, sir.
supramesenteric and portal vein confluence.
Yes, sir.
Are you sure that the disease is resectable now?
What is the
Yes.
question?
Do you get me? One of the sign of resectability is that you pass your finger or any instrument underneath the neck of pancreas and you make sure that it's free from the supramesenteric vessels.
Yes, sir.
Is it the guarantee that the disease is resectable?
The portal veins also we have to see.
I've dissected the portal vein bare, the whole length. Are you sure that the disease is resectable? Yes or no? Or 100%? Where you can get trouble now? You have transected the pancreas.
Sorry, sir. You have transected?
The pancreas.
Yes, sir.
The process of the head of pancreas are you aware, doctor?
Sorry, sir?
You have just transected the head of pancreas.
Yes, sir.
Sir has told that portal vein is free.
Yes, sir.
Not convinced that tumor is operable. You have sort of gone to a phase of non-reversibility. That's a totally
Yes, sir.
different ballgame. But
Yes, sir.
having transected the head, you need to remove something more from the portal vein on the inferior aspect and inframedial aspect. What is the structure of the pancreas which you are concerned if it is involved?
Yes.
Very good. So I think you have done well.
Meera, what is tunnel of love? Meera, tunnel of love.
So the area of post-retropancreatic zone,
Prasad, sir.
portal vein, superior mesenteric vein, the tunnel is called the tunnel of love. Right? You don't normally
Thank you, Kanaka.
vessels to the vein.
And thank you very much.
One more question. There is a periampullary tumor.
Yes, sir.
It is very small on CT scan, on EUS. It is biopsy proven on EUS and biopsy.
Yes, sir.
It's a very small, very hardly identifiable tumor on CT scan.
Yes, sir.
What information do you want from your radiologist so that you don't end up in mess on table? There is no question of encashment or abutment of superior mesenteric vein or artery, right?
Yes,
What
sir.
your information you want from your radiologist other than tumor?
Lymph nodal status, sir.
When the mass is barely visible, there won't be lymph nodes, and that otherwise also your radiologist is going to report. But
Yes, sir.
question: what more do you want technically so that you don't end up in a suit? Most of the times radiologists do report, but still, say if the institute is not having proper exposure of periampullary tumor, in as far as number of cases are concerned, he may miss. What I am interested in knowing CT scan from radiologist, or you will like to go yourself to console and look for certain.
And I would appreciate you give the answer, sir, please.
So what you know is from where the hepatic artery is arising. Is there any abnormal or an accessory hepatic artery or not?
Yes, sir.
You must remember that there can be common hepatic artery arising from superior mesenteric artery itself, and there may
Yes.
not be any other artery.
Yes, sir.
This is one. Second thing, there can be accessory right hepatic artery arising from superior mesenteric artery.
Okay, sir.
There can be left accessory hepatic artery arising from left gastric artery. So
Yes,
these
sir.
anomalies you must ask your radiologist to report,
Yes, sir.
right?
Okay, sir.
Otherwise, if it is the solitary hepatic artery arising from superior mesenteric artery itself,
Yes,
you
sir.
may damage it and you may have to ligate, or you may have to call vascular surgeon, and it can create a havoc,
Yes.
right?
Okay, sir. Yes. Thank you, sir.
Thank you, sir. With that, I think we will come to the end of the session. I would now like to take the feedback from the examiners. Let Abhay sir give the final word. Before that, let me go through Dr. Jayalal, your comment and recommendation for this student, sir.
Really, she has done very well. And
Yes.
as rightly said by Dr. Abhay Dalvi sir, and she has very well clearly passed the examination. And very consciously she was answering to the questions. She is not getting into controversies, and that is good. And we are very slow in answering. That is also good. And I think almost you are done very well. And this topic has covered a lot of good things. And I just congratulate the candidate for the excellent presentation.
Thank you, sir.
Professor G.V. Prakash from Tirupati, your comment, sir.
Yes, sir. Thank you. Before giving my comment, I want to express my sincere thanks to Kanakavel for giving this platform to share today on the happy birthday of Dr. Abhay Dalvi, my friend, guru, and president-elect. And thank you very much, Dr. Abhay Dalvi, once more again. Happy to see you here. And Jailal, my friend, and Sameer, Anandi madam, everybody. Thank you very much, Kanakavel, once again. Coming to this candidate's performance extremely well composed, and wins the hearts of all the examiners, and very difficult to win Dr. Abhay Dalvi. He too really is impressed that you are really got gold medal, Dr. Meera Pariya.
Thank you, sir.
God
Thank you,
bless
sir.
you.
Thank you,
Thank
sir.
you very much, sir. Thank you.
Thank you, Professor G.V.
Thank you.
Prakash. Dr. Professor
Thank
Samir Ranjan Naik from Rajahmundry.
Sir, nice presentation. Dr. Meera, nice presentation.
Thank
Keep
you,
it
sir.
up.
Thank you, sir.
Thank you, sir. Dr. Professor Anandi, madam.
Meera, you did a good job work. I think you have prepared very well and you made it today. Hope you do it in the exam also. Congratulations and all the best.
Thank you, ma'am.
Professor Hitesh Andaria, please.
Mira, congratulations. I was not connected with this link when you were presenting. I like to know from where are you?
Sir, Kerala, sir.
Which medical college?
I am studying in Ramaya Medical College, Bangalore, sir.
Which?
MS Ramaya, sir.
MS Ramaya Medical College.
Okay. Very well done. Everybody tried to pull you, but you cleared the tunnel very well. Very well done. Congratulations. You thoroughly deserve a big applause.
Please pass on our inquiries to Professor Kalevani, madam in Ramaya. I hope she is the head of the department, right?
Dr. Rudresh, sir, is the head of the department. Kalaivani, ma'am.
And our kind inquiries to him. Dr. Ganesh Babu, Professor Ganesh Babu, your comments, please.
Yeah, Meera, you really did very well.
Thank
And
you, sir.
the basic thing what you really make sure in exam is, like what Abhay sir is repeatedly asking is that basic thing. Everybody knows the theory very well. Ripples, everything everybody knows. How we prepare the patient, how we manage, how we console the patient, and how we make fit for surgery. That's the thing you should be very careful. So that's the thing.
Kalaivani.
Anyway, good. All the best for your exam.
Your student Meera Nair. Oh, she is an online. We're taking the exam.
Vivekananda Subramanianathan. Sir, your comments, please, sir. Your comments, please.
Yeah. Good afternoon. Dr. Meera, you have done well. I came 2 times to your college as an external examiner. So you are doing well. So happy birthday for Dr. Abhay, sir. There.
Thank you. Thank you.
Sir. Every day, weekly twice, we are conducting related examination. So you have to tell all your friends also.
Yes, sir.
Accommodate this one. Anyway, all the best. Thank you.
Thank you, sir.
Professor Abhay Dalvi, your closing comments, sir.
Both the candidates were good. This basically reform, I think we have to give full credit to Kanakville for conducting it, and a round of applause to Kanakville because it's a huge effort. The speed, I think, was a little fast. If he slows down, he will be surely a good candidate. As far as Meera is concerned, very well balanced, very well composed. He has moved north from Kerala to Bangalore to study and become a surgeon. As soon as this COVID business stops, there is a flight from Bangalore to Mumbai, and I will welcome her in my institute as an assistant professor for sure. Thank you so much.
Thank you, everyone. I would like to thank Professor Jayalal, Professor Samir Ranjan Naik, Professor G.V. Prakash, Professor Hitesh Andaria, Professor Anandi Madam, Professor Ganesh Babu, Professor Vivekananda Subramanianathan, and Professor Abhay Dalvi for their patience and their valued time for the students. And I also thank the students who presented the cases today and for the professors under whom they permitted to present the cases. I thank all the students for maintaining discipline and quietness. A lot of questions as you have been asking were asked by the examiners. The next class will be on Friday. We'll share the information with you. With that, with the permission of the faculty, I sign off this meeting. Thank you for sharing your time with us.
Thank you.
Thank you.